Thank you. That was a well-deserved break. Hope you all feel better. We're going to continue this discussion on group purchasing, and we will have Dirk continue on with his conversations on his slides. During members of the committee during the lunch break had an opportunity to have Keith Hamilton, who's at the dais with Dirk, come up. He's been doing a lot of work as in the apparatus manufacturing. Is that fair? And working with the hospital association on distribution and group purchasing organizations. And I think his perspective is the missing link that we've been having here. I've invited him. He's going to help us a little bit this afternoon as Dirk winds up his presentation. So Dirk, if you would, please take it away.
Madam Chairman, Mr. Chairman, members of the task force.
Dirk, I'm going to have you get a little friendlier with that microphone.
Oh, sure. Yeah. Whoa.
Thank you.
All right. My name is Dirk Dykesel. Again, I'm with the Blue Cross Blue Shield of Wyoming. And it won't be too long, I promise. I just going to wrap up. We did talk about the GPO model as done through analogy to the liquor division. The state there acts as a wholesaler and aggregates the amount of all liquor that comes into the state of Wyoming and is able to drive down costs significantly. Now, that's not the reason it was done. It was initiated, in my understanding, since I think it was 1935, right after Prohibition, when the liquor division was created. And I can understand that that sounds like a very onerous model, but I would propose maybe an alternative. If the input cost to healthcare is something we would like to tackle, well, then I think there's an alternative model that is done through state contracting, and we already do this. Frankly, A&I already does this through what is known as the NASPO agreement. It's done through a multi-state approach too, and so could this. So while the GPO that is being proposed currently is in the state of Wyoming, within just these 4 arbitrary walls of Wyoming, this could take a multi-state approach. And this could be done where essentially how that model would work is that you would negotiate master service contracts. You'd go to the different GPOs and you could say per different category of implant of supply, whether that's nitrile gloves or whether it is different forms of PPE or even knee implants or other supply costs that come in. There are large group purchasing organizations that are already out there, as we've already identified. But you could negotiate a master services contract, and then you could have eligible entities underneath that could latch on to those master services contracts that could be negotiated on a statewide basis. That helps from some ideas I've heard before. We asked in previous task force meetings, how could we aggregate and how could we use purchasing power? I think some of the ideas previously was how do we maybe get a greater risk pool on the insurance side? This is something that could be done on the input cost side for materials that are used in healthcare settings. It provides greater scale, it promotes efficiency and competition. And that's one thing that maybe I should highlight a little bit further is that a lot of these GPO arrangements and some of the affiliations allow access into greater cost-saving measures. That's one thing I've heard over and over again in my time in healthcare, where if we consolidate and if we regionalize, that will lead to lower administrative costs and drive down costs as well. I don't know that we've seen that translate. So here, what this could be done is by basically just negotiating purchasing, what the state does and does well. So in practice, the state would conduct competitive bids, master services agreements, and healthcare providers, even small rural healthcare providers, could then gain the benefit while maintaining independence in their rural communities and access to that more efficient input price. And it benefits them by being able to access those things that they wouldn't be able to do before. So, and this is just the final slide, and I'll turn it over, is that the tie to affordability here is, yeah, it's indirect when it comes to premiums, and it does go through pass-through of the providers. It's an input cost to providing healthcare, which we ultimately would pay for on behalf of our members, the patients. So as those costs were to go down, we would expect that the amounts charged would go down too. And that's the key measure of success for any policy this group is adopting or considering, is this: if those acquisition costs decrease through coordinated purchasing or other policy developments that we maybe explore, how does Wyoming measure whether those savings are reflected in the amounts charged for care and ultimately to the patient? And how is there that difference currently from what we experience in the professional setting that we know is at the national level to the amounts that we are currently paying for at the hospital setting? So I'll end with that. Thank you, Mr. Chairman.
Representative Pendergraft, please.
Thank you, Mr. Chairman. In your mind, sir, how big a task force or how big a group of people would it take to be able to accomplish that? And would that be perpetual, or would it be like an initial surge and then it could lower, or how would that look?
Madam Chairman, Mr. Chairman, Representative Pendergraft, that's a fantastic question. And I think that's something that we should explore. If we're going to consider this as a solution and a support to providing lower acquisition costs to healthcare providers, especially in rural areas, I don't know that I can identify that number of FTEs or number of state administrative startup costs there. If you did it through, I will say this though, Representative Pendergraft, if you did it through the negotiation of contracts, that's a lower barrier to entry. You're not looking at warehousing. You're just simply negotiating. And I would defer to, we have two different executive branch agencies, and I do not think I'm the best positioned person to answer that question, even though I would love to.
Karen, please.
Mr. Chairman, thank you. The information that I have that came from A&I procurement, I don't know for sure if this really translates over. They've got, I talked with her about durable medical goods, and the gal that's responsible for medical related supplies, equipment, and services. There is a contract, MMCAP, Minnesota Multi-State Contracting Alliance, but that's for pharmaceuticals. So I need to reach out to her and get some more information still. I don't know if any of this translates to potentially savings that maybe workers' comp has something to do with, but the information she provided was that the agency would have to become a member. So I can certainly do more digging with procurement and find out what already exists that we can leverage rather than recreating the wheel. But just wanted to share that information is out there. I just need more details.
Thank you. So then the conversation again at lunch was for insurance providers to understand the premium costs or the claim costs that they're paying. It's really helpful to know what the acquisition cost of the apparatus is. And there's a couple of approaches that we've talked about this morning where we try and negotiate that price. And Mr. Hamilton, if you could kind of explain the manufacturer's perspective and that model, which you explained to us would really drive down or give the option of driving down those costs or the acquisition costs that hospitals or surgical centers, whoever uses, appreciate that. And if you'd be kind enough to identify yourself at the beginning for the record and tell us a little bit about who you are and what you do, and then get us into this perspective or option maybe that you're working with GPOs.
Oh, thank you, Mr. Chairman. My name is Keith Hamilton. I own a couple of medical device companies, one based in Laramie, Wyoming, where we manufacture our own medical devices. We have 135,000 SKUs spread across 95 10Ks. Been doing it for almost 30 years now. And we sell to GPOs. We sell directly to hospitals. So we know a little bit about how the cost models work. The thing I'd say about GPOs is they have their place in the market for sure. And I think what the state is always struggling with is, do we have enough volume to make it meaningful? And the answer is no. GPOs are funded by manufacturers. So if I want my product in the GPO, I pay them. I think the top rate is 3% that they're legally allowed to charge without divulging. So that means
Keith, so that's 3% on
the sell
on the sale price.
Yeah.
Okay. And you talked about a TK something.
a what?
You used an acronym.
510K. Yeah. Sorry, I'll take a step back. So to legally sell a device in the US, you need to have a 510K that's granted by the FDA. And you have to go through pre-market submissions and et cetera, et cetera. The latest data on that is it costs companies about 25 million for each 510K. So that keeps the small guys out. It also, what it does is if you can raise enough money to get, say, one 510K for spine products, you're not going to have the cash usually to get joints and distal radius plates and everything else. So the big companies have a monopoly, the Stryker, the Synthes, and those guys that are servicing the hospitals, they have hundreds of 510Ks. And they've built these over decades and decades through acquisition and getting them themselves. So it makes it difficult for the smaller companies that would drive the price down because they don't have as much SG&A, as much overhead to enter the market. Because a hospital might say, well, I'm part of this GPO and I want to buy your spine product. But if I do, then this guy that used to sell me spine is going to raise my implants, my hip implants. And I can't have that. And so hospitals really get in a sticky situation. And on top of that, we talked about it's doctor preference. That's because an administrator in a hospital can never tell a doctor that you have to use this lower cost product. They'll get sued immediately because the doctor is in charge of the clinical decisions. And you really don't want, maybe my accountant telling the doctor don't use this because the doctor knows or supposedly knows what's best. So what I would advocate for is transparency and optionality. And we've seen this in many industries. Amazon, you see Amazon Basics. Only about 3% of their products are their own brand. Everything else is somebody else's brand. I've sold into automotive. In automotive, you tell them what it costs to make the product. That means your raw material, your labor, your SG&A. Electronics is the same. And then you put that on top of it. So then you can argue, should you be making that much money? But they can never argue, can it get cheaper because metal costs what metal costs. So in healthcare, the reason they can't do that is back to that 510K, because there's not enough people that own 510Ks that can do that. So for the state of Wyoming, for someone like me, a manufacturer that owns those 510Ks, you could take a very large GPO that has access to all the name brands, and underneath it, roll a layer of, let's call it Wyoming brand or house brand or generic, just like pharma did, products. Then a hospital could make the choice. As long as the generic gives full price transparency. So they could look at a schedule and a drill bit says it's $12 to make it. SG&A is $12. We're going to sell it for $24. And then when the big guys, the name brands come in and say it's $90. Why? I can buy it right now. Or they can choose to negotiate. Say, I can't pay, $90. Give me a break. How about 60? Right? So giving hospitals that option, then they can start to negotiate with everybody else, insurance companies, with doctors. I was talking to some doctors at a major tier 1 medical center out in the Midwest, and they just fired a doctor because it cost more in implants to have him on staff than he brought revenue to the hospital. And this is unfortunately all about money, right? Each orthopedic surgeon in the field I work in, they bring about $2 million of revenue to a hospital. If they cost more than that, they're going to get canned. And hospitals are starting to look at that. So a hospital can't say you have to use this cheaper implant, but they can say, can you look at some alternatives that are still give you the same patient outcome? So when we talk about, okay, what do you put in this optionality GPO house brand? Well, whatever the hospitals ask for. As long as you have the 510K, they might want ureteroscopes, or they might want sterile packs for surgery. So that way, if the hospital is currently buying from this big kind of this over umbrella GPO and they love Stryker and they're using Stryker, please use them. But maybe I can save money on laceration packs for my ER or bedding or masks. And then Wyoming has an opportunity to make some decisions and with some of the grants they hand out. For example, when you're working with a manufacturer like us, we'll tell you, A mask machine that can make every mask Wyoming would ever use in a year will cost you $575,000, 100% automated. You could put that in any city in Wyoming and make every surgical mask. That's pretty impactful. So now you have an option for made in Wyoming, and you have an option for doing that because you own the you own the 510K. So you can know with a lot of things, drill bits, K-wires. A lot of the stuff we make is actually made in Laramie. So that's kind of the state of where everything is going now. Hospitals, if the current GPO state was the panacea, you would not see every hospital in the country, just about every hospital, struggling. The ones that aren't struggling are doing some pretty crazy things. They're buying other companies. Then that company is offering services to the hospital, it blows up the revenue, and then they sell the company. And that's a really common strategy. A lot of hospitals are getting bought by venture capital firms. They're not making money off of delivering healthcare because it's too expensive. The price to make is too expensive. So all we're saying is, yes, use the big GPOs, but start from a level of transparency and honesty where everybody sees this is exactly what this costs to make, what margin is going on it. Because our data shows over 15 years of looking at hospital data, the average markup from what it cost me to make something to what it's eventually sold to a hospital for is 720%. It is insane. But the companies that have done it, they need a lot of money for R&D and all of that. And all I'm asking is that they pay for that R&D, right? So if you go to a hospital and say, I don't want that whatever house brand, well, then what makes your product so much better? And they sell on that, sell on the features and benefits, just like we do with automotive and everything else. So, but I'm happy to answer any questions on GPOs or how the manufacturing works or any of that that you might have. Thank you, Mr. Chairman.
What do you think about that? What do you think about it?
You need to think about it for a minute. I've had the luxury of hearing this partway, and then so I'll go next to Director Johansson. But what I'm hearing you, and please correct me if I'm wrong, is
Do you want to make our masks?
I would have a machine in Germany right now ready to come over.
but everything is currently in place to put that type of purchasing system in play for hospitals, surgical centers, clinics, without the need for the state to do a policy issue. Now, we could still buy the mask machine if we want to, but the system of forcing the pricing with the larger GPOs and whatnot, can that be done without the state being a part of that?
It can. The state could definitely help out in grants to put in mask machines or things like that to help to add innovation. But really, we're talking about just letting the free market. We're adding a layer just like they do at Amazon that says here's a layer, and you cannot charge 5 times more for a solo cup because there's a solo cup there, and they're just not going to pay it. Now, does it solve all our problems? No, but it does for hospitals that are challenged. They can look at their spend ledger and say, I want to keep this because I like the rep, but I want to move these 17 items over, and what will that save me? And they'll know there's pure transparency. The state really doesn't have to, in that regard, do much at all, I wouldn't think. Hospitals need to be aware of it. There has to be a real education when you talk to hospitals about, let's look at what you're purchasing and why you're purchasing it, and that there's alternatives. But as far as the regulation is concerned, the companies that we own and other medical companies, we handle all that, and it is onerous. Even as a distributor, you're responsible for tracking everything. And that's why something like the Wyoming does with the Wyoming Liquor Board gets really, really problematic when it comes to medical, because if somebody takes a shot of liquor, and gets in a car accident, you don't say, where was that liquor made and what barley field did it come out of? In medical, we do. And so companies like ours, that's what we also specialize in, is is making sure that everything's recorded properly so that if there's a recall, we can recall properly. And some of the other things that make sense is we do a program right now in Laramie for very large companies in the US where all the surgical trays come to Laramie. We restock them, we record what's in them, we wrap them, and then when there's a surgery, we send it out to them. And it's usually within a day or two, the surgery will send it out to them. The reason they do that is if you were to start a company like that and you wanted 1,000 hospitals to participate, you'd have to buy 1,000 of these basically toolboxes full of medical implants. If you do it this way, centralized, I only need like 100 because not all of them are being used at all at the same time. So for a state like Wyoming, we use how rural it is as a strength. So we're looking at different ways to solve the problem. Why do we need every hospital to own the same joint tray if it all goes back to the same place to get refilled? They don't have the workflow to categorize everything at the hospital. That saves them time. It comes back ready to go in their sterilizer, so they don't have to hire that extra employee that they can't find anyway. And then the paperwork's done locally in Wyoming, so to speak. So there's a lot of workflow things you can fix when you're dealing with a factory. Some surgeons will complain the trays they get in are, there's 6 to do a spine surgery. They only need 3, but they all come in there and parts go missing, and then the hospital has to pay for it. In fact, right now, the average we see of trays coming back to us, 30% of the time an instrument is missing and the hospital pays for it. We have a 30% call rate. And believe the scissors, just the scissors, are $730. And 30% of the time they're gone. So what we do is it comes in, we know it's gone, we know who to charge. And then it gets charged to the patient, it gets covered that way. So when you have that optionality of, okay, I can make the tray any way I want, I can put anything I want in it, it can improve efficiency in the OR, you can really test, like what is really getting lost and what isn't getting lost and what am I using? So transparency and optionality, those are the 2 things on everything. So the state really doesn't have to do much more than just, I guess that I don't know if there's oversight or not, but it's working with the current partners within the state now to set it up. They're currently in interface with the state.
Director Johansson. Okay.
Will he stay for the anti-trust?
Are you going to, the question out there is, are you going to stay the rest of the afternoon? Oh, buddy.
I cleared my calendar too, if needed.
Thank you.
Yes.
Thank you. There's some other topics that we might call you back up on.
Sure.
Okay. Eric?
So thank you, Mr. Chairman. I'm glad you stayed. I'm glad you're here to answer these questions. This is what we were alluding to earlier when we talked about a Wyoming Hospital Association solution to this. And obviously, I think a layer of GPO is also needed, which we found a solution for too, which we talked about with our small roles that maybe don't qualify for some of the bigs and have that purchasing power. But we're really intrigued with this, and it's just we've been working on this for more than a year, maybe more than a year and a half, but all the pieces are finally starting to come together. We've toured their facility and Laramie and had good contacts with the GPO that we're entertaining contracting with. So I think we do have a potential solution here to a lot of the problems we've discussed.
Mr. Chairman, Mr. Bowie, I would add this one thing. From when it's hard for us to approach GPOs. I mean, we sell through GPOs now, but it's hard for us to approach them without someone like the state or the WHA to put that together, because the GPOs, they make their money off a percentage. So they don't want really anything cheaper in there. So it takes someone else to set that up. If that makes sense, it takes another entity to say, hey, we want to do business with you, GPO. We want to drag these guys with you. And we know you're not going to like it, but we need it because we need this transparency and optionality. And for, over a decade now, we've talked to GPOs and they're all like, that's a great idea. It could save our hospitals money, but we're not going to do it because they stand to lose money. So to your point, it's manufacturers, small manufacturers need that help of mashing that together. And
so is that done, if I may, I apologize, go ahead and finish and then I'll butt in on you.
there's lots of small manufacturers around Wyoming that can take part and add to this as long as they have access to the 510K. So one of the things we do is we allow people to use our 510Ks as long as we're in control of all the compliance. And through the FDA, we can do that. So a small manufacturer that I know there's some guys in Cody, has a great idea, but can't afford to get the 510K, but still wants to sell a product to someone like that through the state of Wyoming, they can, for all intents and purposes, lease that. And we'll handle all the compliance. It's a service that we offer. We're the only company in the world that I know does that now. And they can begin manufacturing it and selling it, and we do all the quality, we do the audits, we go see their facilities and make sure that everything's on the up and up. But it's I think this is a huge breakthrough for Wyoming to do something like this, because we can use manufacturing local to us. Yeah, so I grew up in Sheridan, so we had a lot of manufacturing up there, and it was, there's still a lot of companies out there that could take advantage of it.
So then my question, and I guess I'm looking, Stefan, at you, is do we need something statutorily or through the rule, or I'm trying to understand what we do to give this incentive. Do you have any thoughts on that?
Mr. Chairman, I need to think a little more deeply about what state direction legally or through statute would need to be. I'm not coming up with it now if the ability exists, but perhaps to the good speaker's point, it seems like perhaps if the state wanted to incentivize that type of manufacturing participation as an option for healthcare facilities or health facilities, then looking at that as part of grant making that could be available or subsequent years of rural health transformation is intriguing. But I was glad to hear what was mentioned about just Wyoming's volume really prohibiting the full effect of this GPO idea, which absolutely makes sense in concept. But as I mentioned in our first meeting, operating 5 24/7 facilities, we've had all of the discussions with GPOs as well, who might be an overstatement to say they laugh us out of the room, but they say, hey, 5 facilities, a couple hundred patients, there's no deal even if you join with us. And one in particular, I won't mention the name or the service line, said basically if you and every other small hospital in the state joined, probably not a big price break either. It's just the logistics, the geography of Wyoming are tough. So I'm intrigued. We'll certainly follow up both selfishly for our facilities, but also for state policy as well.
So the way I understood it, though, is you could have the option for the hospitals to buy it direct from the manufacturer.
Mm-hmm. Yep.
And which is what gets the GPO's attention. They can buy it at the manufacturer for $25. We can sell it to them instead of at $90. We might have to go down to $50, but $25 is better than nothing. And so the incentive is that you can't, how do we direct the GPOs in not charging whatever percentage that is over manufacturing price? If I'm getting this in my head right, and maybe we need some time before the next meeting to flesh this out a little bit, but so I would entertain a motion on this unless there's more questions. Sorry. I just move us along. I think this has value in how we do that. And I think with this ever increasing information that we may be back a step away from the liquor model, but then maybe have Director Johansson and Representative Pendergrass.
And I'd make that motion to, I guess, to have some sort of we need something in black and white. And I need something that tells me the scope of, how much product are we talking about altogether? We save 2%, what does that come to? And then what would it cost to administer it? Some sort of a proposal like that I can look at tangibly, and I would love to see that.
Say that. Rocky, then Stefan.
Yeah, I mean,
Thank you.
thank you for joining us today. I'm actually very fascinated by this. I mean, I knew there were manufacturers in Wyoming, but I didn't realize the extent of it. So this is super helpful for us to have information about. I think it's a good place for us to be in as a state, to be able to have an opportunity like this. I think the thing that we're talking about here with affordability that could be helpful as well is, when we're talking about contracting with the state, the GPO idea adds that value for transparency. So in this situation, maybe the contract wouldn't need to be held by the state. But I think, in working in healthcare, group purchasing organizations, statements of work, SOWs, there's a lot that goes into those, right? You can talk about invoice prices, or you can talk about volume usage. And if there's enough volume usage, you get a rebate or you get a discount off of that because you've used enough volume to get that discount. So the invoice price actually becomes a different price at the end. And that savings that I think that you're able to get in order for it to be valuable in this kind of a context would need to be passed to the consumer as well, right? So what we could do is find a way to make full transparency. And I think that's difficult because in contracting, as I'm aware of, is that there's a lot of confidentiality that comes with that. So if we're able to have a full amount of transparency as to the actual cost, I think maybe Representative Pendergraft brought it up, that we could calculate the savings and then we could flow that into some form of accountability. And it's not just accountability for providers, it's accountability for health insurance companies as well too, to say, okay, we've been able to reduce the cost of this service by this much, and we've been able to reduce the cost to the members and the premium payers by this much as well. And if we can measure results in that way, then that's a win.
Director Johansson.
Mr. Chairman, at the risk of oversimplifying the motion that was made, but maybe to clarify, Representative Pendergraft is amenable. I'd motion to table this bill, not to get rid of it, but I think the concepts are valid, but table the bill at least until our next meeting, giving us, the Department of Health or the task force, the opportunity to further explore this concept as an option within this purchasing power arrangement we've been discussing.
Second.
Doesn't need to be seconded. It's a motion to table, it's done.
Oh, that's
It's
right.
tabled then.
Motion to table.
It's
Thank
been
you.
tabled. Yeah, I mean, a couple, couple concepts here. We have 2 more meeting days, 3 total.
That's correct, October.
So we will not have an ability to bring anything further forward. Unless we make a motion for another bill draft today and tomorrow for our next meeting to then adopt. Because this was just a working draft conceptually, not a draft to adopt. And so what you would do is you wouldn't be an aye vote or a no vote, it'd be an amendment or further drafts to be created. And this is the work of the legislature of understanding the timing of when we would have a work product to produce when we come to an idea. And without that work product in place or that tool in time, there's nothing we can move forward before the session starts. So just those logistical limitations to be mindful of, even though it really feels like this bill draft is not ready, not even close to ready for prime time, but it was just a conceptual starting place to make sure we had it on the agenda for our review. In no way, shape, or form was this even close to being ready to move forward, but it got us the conversation to move forward and understanding what different versions of it we want to see. So I would ask for a different version of it so we have something at our next meeting, because this just got tabled.
Is that a friendly amendment to the friendly amendment?
The bill is gone, which is fine. I mean, because we're going to do a new bill draft. Again, conceptually, so we have a product to work with and amend at our next meeting in the event something very exciting comes out of any of these opportunities, right? And so placeholder bills is what we're really talking about here, but generally in the same subject matter.
I'll go with Pendergraft.
Thank you, Mr. Chairman. I appreciate what you're saying. I think that's part of what I was trying to express when I said something in black and white. We need something tangible that we can start with that is a foundation rather than just carrying on a concept that we'll take up this conversation later.
Well, we can make
But-
it in black and white through a bill draft.
Yeah. Yeah. And so that's what we'll do. Eric,
Mr. Chairman, so obviously there's a lack of trust between Blue Cross Blue Shield and the hospitals. I'm a little bit hesitant we're ready to move forward. We've been working on this. We're ready to move forward. So I guess the question I have is, do we stop what we're doing? Stop the negotiations and the contracts that we've been working on with the GPO and with this group so that we can work on that? And then as you look at it, the earliest we could really enact anything and move forward is April maybe of next year. So I guess the question is, and we're willing to work with the insurers to try and address their distrust of our transparency issues. But I think it's time to move forward.
so, I'm not the sharpest nail in the room, so maybe something's missed. I've missed something. But I'm not getting the sense of distrust. I'm getting the sense of trying to figure out how we get to where we can adequately influence the cost of insurance and the cost of medical care. That's why I'm so grateful that you and Mr. Red have agreed to help Stefan and I between now and October come to a draft that we think fits this whole model.
Point well taken, Mr. Chairman. But I do have the question about, so we should cool our jets then and not proceed with what we've been working
No. I
Because you
don't
wanna
think
put
we're
a contract in
suggesting,
place.
I don't think we're suggesting that at all. I think what we took away is that there may be a place here for the state to incentivize this type of model. We don't, it's what I've heard, and I think that's what we're all trying to flesh out here a little bit. If it's not needed, we can make that recommendation when we come back in October. But if you guys feel that there's not a need there, that's, so be it. But that's why we asked that question back. Is there a role for the state? Is there something the state needs to do? And I think I heard possibly so. That's why the four of us will work on that. And if.
I mean, Mr. Chairman, I mean, we could do the flip analysis, which is, should the legislature just stop working on trying to find ways to make healthcare more affordable, particularly when it relates to something finite like a commodity associated with healthcare costs? And the answer is certainly not. And the same is true for you, which is you need to keep working on behalf of your hospitals to find ways to deliver care that's more efficient and more affordable. And we will continue to work together on that, coming up with the best solutions. So, because you're working on something that may or may not come to fruition does not mean that we should stop working on it either. And so we both shall endeavor forward with two brilliant people in front of us that are going to join the team.
And I really do. I think I heard that you guys been working on this for a year and a half, something. Perfect. But is there a need for the state to help get that somehow implemented? That's what we're going to work on. If we don't, great.
He would like a grant for mask manufacturing equipment. And that's what I heard very clearly.
Yeah.
That we're gonna go into
Really a lot of
making
ways that
masks.
this conversation can develop. And I think it's important that it does.
Yeah.
And
Thank
we
you.
don't lose our focus on this.
So with that in mind, we look forward to working with these two good guys and their designees. And Keith, don't be surprised if we call. Thank you.
We will be calling.
We will.
Trust.
Yeah, he's agreed to. I think, Madam Chairman, we were scheduled for general public comment on everything up through this. Is there anyone here that would like to make any comments on the Title 25 allocation, the making healthcare more affordable. Anything on this, of what we've covered thus far? And is there anybody online that would like to participate in that? As I'm looking at I'm going to guess that Mr. Schriftman was probably going to be more towards the end of tomorrow.
Mr. Chairman, Mr. Schriftman just raised his hand, but I'll defer to you on when you'd like to.
Well, as I read his information, I think that really comes into play as we look at bear care and reassurance and some of those other things. So I think tomorrow would be better. Jen Lowe, I would assume, would be tomorrow on Healthy Wyoming. And then I think the next person I think was pulled off. Okay. Anyone in the room? Very good. Let us then move to item number 9, the non-compete agreement is a bill. Yep, it's a bill draft that we asked for last time. It's Anna, if you'd present this, and if I may, Madam Chairman, this is a continuation of a process. So if you'd kind of guide us through this as she finishes the bill and anything we need to understand.
That's the sheet.
Both of you, start with you, Anna.
Thank you, Mr. Chairman. Anna Johnson, LSO Staff Attorney. This bill draft in front of you is entitled 27 LSO 77 Prohibition on Non-Compete Agreements Amendments. And this bill draft was requested at the last task force meeting. So section 1 on page 1 indicates that 2025 Wyoming Session Law, Chapter 170, Section 2 is repealed. And then I do have that language in a staff comment beginning on page 1 and continuing on page 2. Essentially, the bill draft would repeal the grandfather clause from the 2025 bill draft that prohibited certain non-compete clauses in employment contracts. That bill did not apply to contracts that were entered into before July 1st, 2025. And so this bill draft would apply that law to all employment contracts, regardless of when they were entered into, whether before 2025 or after that. The staff comment indicates that by removing the grandfather clause, the bill draft might be argued to violate the contracts clause of the United States Constitution, which states that no law shall be made that impairs the obligation of contracts. Because the 2025 legislation would now apply to all non-compete agreements, regardless of when they were entered into, it could be argued that this bill draft impairs contracts that were entered into when non-compete agreements were illegal in the state. Furthermore, by repealing the grandfather clause in the 2025 legislation, the bill draft might invalidate contractual non-compete clauses that were originally valid under the 2025 legislation. And that's just something for the task force to consider. And then section 2 on page 2 just provides an effective date of July 1st of 2027. And I would be happy to answer any questions.
Any questions? And then, Madam Chairman, if you just take us back through that history again.
Sure.
And if you can address the concerns of the staff comment. If you
Sure.
have any.
I just saw them for the first time, I have to admit, but I'm prepared.
Good.
Thank you, Mr. Chairman. As the committee may recall, it was my motion to have this bill draft brought forward based on some testimony we received at the last meeting, and that actually has been ongoing in the country for a number of years now regarding the impact of non-competes concerning its effect as it relates to this committee, the cost of healthcare. And so the legislature previously passed a prohibition on non-compete agreements that included a grandfather provision within it. This bill draft is really just repealing that grandfather provision. What we know is that, or what I'm aware of, is that there was a run on non-competes up into that July 1st date. And so a number of providers and other entities really rushed to meet that deadline and put a number of healthcare providers in our state under non-competes. And then, of course, there's ongoing obligations for that. What that does is it eliminates the ability of those providers to provide services in our communities that are critical and actually enhance competition and the free market. Some of the concerns addressed in the staff comment, I intend to evaluate further, but am not very compelled by them. The reason for that is the Wyoming Supreme Court has continued to essentially outlaw non-competes with continuing regularity as a result of the increasing practice of those being litigated in all kinds of industries, but notably in healthcare. And so that's not unconstitutional for the court to declare a non-compete to be unlawful and therefore void or in effect for a variety of reasons that the court considers. Additionally, the Federal Trade Commission was working pretty extensively to enact a rule that would have banned non-competes across the country. There were thousands and thousands of comments entered onto that rule, particularly hundreds from the state of Wyoming, particularly from healthcare. I think it'd be notable maybe in your spare time to go take a look at those comments from that FTC rule to ban non-competes to really get a fuller appreciation of how these are actually increasing the cost of care, hurting patients, and harming providers in their ability to get work in the communities where they currently live. So although I appreciate the staff comment, those are legitimate concerns. I feel confident voting for the bill and moving it forward as being constitutional.
Thank you, Madam Co-Chairman. Any questions, Representative Pendergraft?
Thank you, Mr. Chairman. I signed a non-compete. I had been a private contractor most of my life, went to work for a large partnership in Sheridan and had to sign a non-compete to go there. And of course, part of what they're trying to protect is their methods. They're trying to protect their list of clientele. You know, I go in and serve those people for a few years and then decide I'm going to take that over. That's a problem. I guess my question is, what is the role of government in this? Do we have a right to intervene in a contract agreement between an individual and a corporation? I don't feel that we do. And if there is a dispute in that contract or someone violates the non-compete clause, that's why we have litigation.
I do know that.
Yeah, I know. That's something you know much about. So I'm trying to say, what has the legislative branch to do? Why do we think it's okay to interject ourselves into a private contract?
Yeah, Mr. Chairman, we can talk about the policy of the need to regulate commerce, particularly as it relates to the constituents in our communities who don't have access to healthcare. I'll demonstrate that through a story. But there's one concept I want to distinguish for you, which is a non-compete agreement and a non-solicitation agreement and/or a confidentiality agreement in an employment contract, as well as what's called a trade secret. And so we have adopted the Uniform Trade Secrets Act, and there's also federal law for trade secrets, which would protect a company's information that you identified that you were tasked with not using. And that would include customer or patient lists. And that's also part of a non-solicitation agreement. This bill for non-competition doesn't deal with those concepts. This bill says, if you are a trained professional, for example, the case that went before the Wyoming Supreme Court was a CNA, so a certified nursing assistant who worked for a home healthcare company, who developed a relationship with some of her patients, and one of those patients wanted to hire her full-time and have her come live in the home to take care of their child. Well, she was under a non-competition agreement with her $10 an hour. And she took the job there. She went to go work for the family who wanted full-time round-the-clock care, somebody to live in there with their child and who they had developed that relationship with. And she got sued for all of her $10 an hour. And she got sued all the way to the Wyoming Supreme Court from her large corporate employees. And so who really did that harm? It harmed the family who wanted that nurse in their home, who had developed a relationship with their child. It harmed her ability for upward mobility and to make more money on a trade that she earned. So in some ways, you could say that a non-competition agreement actually just enables corporate welfare, which I know we're against. And we don't support corporate welfare, but it creates an unfair, anti-competitive environment, which hurts the economy, which hurts our constituents, and ultimately hurts children who are in need of round-the-clock care from a CNA who loves them. There's the story.
Please.
And thank you for that. It's very similar to the situation that I found myself in when I retired. Is I had a number of their own clientele coming to me and saying, you know, we've developed this relationship. We really want you to do these things. I decide not to. But the question then comes down to, didn't that case that you cited with the CNA get resolved without this law, without yet another addition to the Green Book? And couldn't that be resolved by, as I mentioned earlier, some sort of legal action without? Aren't there enough? My question is, aren't there enough laws on the books currently that these things can be resolved without adding more to it?
So maybe. But I think the argument there would be is you're pulling a law off the books and replacing it with this. You're taking the law off the books that says you can require a non-competitive competitive agreement in order to work here or perform your services, and that's being removed, and the new law is that you can't do that. So it's not adding to.
So then we remove the burden between two individuals in their contract, and the state steps in and preempts that. Am I seeing that correctly?
I don't think so. I think we as legislature craft the laws by which business is conducted in the state that we feel is most equitable to all citizens and businesses of the state. And I think what is being suggested here is that the current law is not very equitable. And yes, there's recourse to solve the problem through the courts. The argument is, why should that be necessary to begin with? And so I don't think we're sticking our nose in the middle. We're just saying these are the guidelines which for business and these type of agreements in the state. Did I say that? Kind of. Motion on the bill.
So moved.
No, we
Did
didn't.
we move?
Did you second? Second. So task force members, and we'll do a roll call vote on this, Anna, and I'm going to ask that it be directed to the Joint Judiciary Committee to review and move forward there. Well, again, we're not a legislative body. We're making this recommendation, and as we have done in previous task force. So Anna, if you would please.
Mr. Chairman, this is a roll call vote for 27 LSO 77, Prohibition on Non-Compete Agreements Amendments. Senator Crum,
Excused.
Senator Love.
Aye.
Representative Geringer,
Aye.
Representative Pendergraft,
No.
Mr. Boley.
Aye.
Director Johansson, Mr. Rudd,
Aye.
Commissioner Rude,
Excused.
Ms. Williams.
Aye.
Co-Chairman Nethercutt,
Aye.
Chairman Larson.
Aye.
Mr. Chairman, we have 8 ayes, 1 no, to excused.
Thank you, and thank you for the conversation, particularly the construct as we go forward. I think that'll be a good conversation for judiciary. Okay, thank you. Denise, how did she do? She did do good. Let's move to bundle billing payments. Eric, I think you and Karen, Rocky, have some conversation on that. We'll start that conversation with kind of how we do bundle payments now. Kind of the conversation we had is before we start this afternoon, please.
Mr. Chairman, you want me to stay here?
No, we're fine. We're all here.
Mr. Chairman, I'll try and take us back to the end of our last meeting. We were discussing the opportunity to maybe drive down costs through bundle payments, and it's been a practice that's been in place for several years. But in essence, you take a procedure. We may as well just stick with these for right now, I guess is a good one. But basically, there's an agreement between the insurance company and the provider to have an all-inclusive bundled payment that covers the entire procedure, including anesthesia, all the equipment, the hospital charges, the physician, surgeon fees. Some of them actually have built in the potential for readmissions or complications. But we've found in certain circumstances where that can be a cost container and can help drive down the cost of care for individuals. Not always, I would say not always is quality a big component of that. A lot of times it has more to do with just cost containment, but I think there are some opportunities within our state to look at potentials in some of those areas, and it might be something that we can grow, starting out with a couple of common everyday procedures and then moving forward. We've had conversations with our hospitals that have wanted to contract for those, and it hasn't been widely accepted, both with insurers, and also I think we've had conversations for the last several years with the state employee plan as well. And I trying to go off recollection, I think potentially there was an issue with software and the ability to build that with the TPA. I can't remember for sure in some of our conversations, and not all of our hospitals are ready to set that up, but I think it's one of those tools that we could use to help contain costs, drive down costs, and potentially create more economies of scale as we drive more of those procedures to these facilities that do have bundle payment arrangements.
How so on the last end?
Well, Mr. Chairman, I might let Blue Cross Blue Shield talk about what they're doing currently in an attempt to contain costs, but they have the ability to help direct care to certain facilities. We do have a couple, I think maybe 3 now that have Blue distinction, which is a designation that Blue Cross Blue Shield gives to hospitals that have, and I don't know it as well as they do, but certain number of procedures, certain price range, and also quality metrics that are met. And so in the past, because we didn't have enough volume, I think in certain circumstances, there were cases that were being directed or recommended to leave the state to go to a Blue distinction center and bypassing some of our hospitals. And so that Blue distinction has really helped us to be able to capture more volume in our state by meeting the criteria necessary for that Blue distinction. I think the same could be done with bundle payments.
Okay, Karen?
Mr. Chairman, thank you. The information that I have was from an Aon study that was done in 2021. And if it's all right, I'll read some of this information to you. I've got some high level information that suggests that it isn't likely workable, but it's having the discussion is the important part. 2020 budget session, Senate file enacted a request for Department of A&I to take a report on findings and recommendations required under this act to the Joint Labor, Health and Social Services Interim Committee. That report was delivered in 2021. Bundled payments require participant providers to assume risk as they must cover the cost above the target price for an episode of care, including those that arise from complications and hospital readmissions. Aon Consulting and Surgery Plus outreach to multiple Wyoming providers while developing the report. Some of the key pieces in here, I don't want to read you the whole thing. I've got about 13 copies. I'm happy to pass it out. Healthcare systems in rural areas don't always have the luxury of attracting board certified fellowship trained surgeons. In addition, surgeons in rural areas don't see as many cases volume versus those in urban areas, so the volume of each procedure type performed is drastically reduced. Many members in rural areas are already required to travel for care, and to access a high-performing narrow network would increase this travel likely out of state. Steering members away from rural care to major metropolitan areas can have a positive impact on quality, member experience, and cost for members and a planned administrator. A program like Surgery Plus can give members more options, the right high-quality options, provide a concierge experience at a fair price for care through bundled centers of excellence programs. But building the network capabilities in Wyoming would take time. Likely that, at least initially, most of the care would be provided in this situation as they reviewed it with the Surgery Plus Center in Colorado and Utah. Quality requirements. So the other information I have outside of this document that was kind of a summary of that report is just that typically bundled care is both quality metrics and cost. And those quality metrics, because of the low volume, there's not enough. I mean, going to a provider that does 2,000 knees a year versus a provider that does 20 in a year, you're not going to have enough statistical information to measure that quality metric. So again, I think it's always been, and I said it in the last meeting, and the way that I describe it is shop Cheyenne. I'm all for keeping and retaining and keeping the care in Wyoming. But how do we get the volume to get the lower prices versus lower the prices and then you get the volume? So the other thing is if you've got 3 providers that are all an expensive provider, typically contracts don't get negotiated down as far as the allowable cost. So it just seems a little bit hard pressed to think that potentially 3 expensive providers, not to sound derogatory, are going to accept an even lower rate when what they don't want, they want more due to inflation and cost of care. So that's the information I have. And I'm happy to share that Aon report, albeit, 2021.
Isn't there some argument to be made of the illustration you had of 3 providers, that if one provider then took a bundled payment that overall was costs less, that then the volume would generate more revenue than the other 2 who were more expensive?
The less complex services would allow for the potential of the provider still saving money, even though they've accepted a bundled discounted rate. I think the cost comes into play when you've got a situation where there is complications or there is readmissions. Anything that arises from that bundled payment is all going to be covered in that lower cost. So there's definitely pros to it. My biggest concern on the state program is always making sure, how do we balance not steering care out of the state? There's times we've discussed in the past that it's necessary because we don't always have the specialties. But how do we keep people in Wyoming when care is often cheaper? A bundled payment in Wyoming may still be more expensive than care over the border in any of the 4 borders. So it's. So
you're saying, from your perspective, bundled payments are more expensive?
I'm suggesting that bundled payments in Wyoming may not be the cost saving that we think they are.
Fair enough. The structure of the payment, in my mind, would suggest that it would cover the cost of, we'll call it an average surgery on this knee, but if you can get it done faster with, whatever it takes to reduce the cost, then you actually are doing it and getting to keep the extra. Whereas if there's complications, then you would have to absorb the extra, right?
Correct.
Eric, please.
I think you made great points, Karen. And honestly, I don't think that a bundle payment makes sense in every setting in Wyoming. I do know there are willing and active participants that have requested this, and one of those is here in Cheyenne. And I would venture to guess, I don't have the data that you guys have, but I would venture to guess that they would be very competitive in pricing. And I think that's all part of the negotiation as well. But some of our larger facilities, I think there might be some significant savings and the ability to do that. But I wouldn't say that we should go out to every critical access hospital and say, hey, let's do bundle payments, because they're going to say no way. But I do know there are couple that are very interested in this concept and exploring it if it was an option.
Mr. Chairman, I would agree. One of the things that I think is important here, and I'm reminding myself of it as well as the room, is, as Blue Cross indicated, whether it's a 1 or 2 or 3% impact, that's certainly better than nothing. So where we can get savings, we can. So it's something that's worth looking into, where we can get it and it's effective. In the past 30 days or so, conversations I've had with a facility, I get a little bit nervous because there isn't an access issue. We do incentivize our members to stay in-state and in-network. But the problem that's broken with that is, like I said, 75% coverage on a service that only costs $3,500 versus an 85% coverage on a service that costs $16,000 doesn't incentivize someone not to still go to Colorado. So if there's a way that we can work on something there's still choice. If a member wants to go down to Colorado, they can. But if there's a bundled payment, there are people that would prefer not to make that drive. So I don't think it's throw the baby out with the bathwater. It's not as you said earlier, it's not a silver bullet, but maybe there's room for conversation about how to do that where it is most effective. So.
Mr. Red?
Thank you, Mr. Chairman, and I appreciate the comments that Director Williams provided here today. I think, we offer value-based care solutions, opportunities for the providers in Wyoming, and they're limited, I think, because the uptake on those is low. Value-based care is difficult because it has to have teeth. There has to be something associated with the payment to add that extra level of quality that would be the expectation. And I think that adds another administrative burden when you're talking about value-based care, because you have to go in and you have to look at whether the service was provided in a quality way. Also you look at volume too. You look at how many procedures they're providing and whether or not, that's an indicator of quality, because you're seeing it happen over and over and over again. And so we have to provide value-based care opportunities for providers, and we do. So we have those options out there and available. It's different than, like a flat fee or capitated payment, which is just something that you would just pay at a fixed amount, or a DRG. A bundled payment would include the DRG, so it would be the total episode of care.
So Rocky, I'm going to have you resist using the acronyms quite so much.
Okay. Yeah. The DRG would be the diagnosis related grouping.
Yeah.
Yeah.
And can I go back and have you help us define the value-based care? What distinguishes that? And then are you suggesting that bundle payments fit into that model?
Yeah, Mr. Chairman, thank you. And I apologize. So yeah, VBC is what we refer to it as, and it's value-based care. And it has to have teeth, meaning there has to be when you're paying that global rate for that total episode of care, you want to make sure that you're getting value out of that service. And if the value is there, then there can be additional payment opportunities for the provider, which I think supports that idea, right?
We're going to talk a little bit more about it today, but having higher cost is not, it can very well be an indicator of quality. And we understand that. So we want to incentivize providers to provide quality care, and we would be willing to pay them more for that quality care, but it has to be verified. And so it's not a trust issue. It's not a trust issue at all. It's just a verification that that's actually what's happening. It's a measurable result. It's data, you know, and we all have to be accountable for that kind of thing. It's just a simple measurement of the value of what we're providing, whether it's in our own job or whether it's in our own, you know, family. I guess it's just data, and data is useful. And that data in value-based care is one of the most important things that we measure in order to determine whether or not the service being provided is worth that extra value. Mr. Chairman, I'm not sure if I answered your question. I could give you more of the framework. Okay.
So can you help us apologize. Can you help us understand, do hospitals make the request then to you, or the healthcare provider make the request to you? Would you consider doing bundle payment for this procedure? Or is this something then that you propose to them, that as you've looked at their data, you would propose a bundle payment? Tell us how that gets started.
Mr. Chairman, absolutely. So with the blue distinction, that's actually, I don't want to get this overly complicated, but the blue distinction is something that the Blue Cross Blue Shield Association does and provides for. And these are usually services that are the center or the hospital within that area is considered excellent for providing that service based on those measurements, the amount of services that they provide, the quality that's provided. And those services are specific to certain things. We also have our own state-based, we call it the Circle of Excellence. It's a little bit different, but that's where we've gotten into actually hips and knees and things like that. So we would bundle those payments and make payments for those services based on similar metrics, as you would see in the blue distinction. But those would be, blue distinction would be more like the DRG services, the bigger services that are inpatient, as opposed to the Circle of Excellence, which would be more like these outpatient services that we've been talking about a little bit today, where you could bundle those payments as well.
Do you ever consider the structure of the bundle payment to, I don't know, maybe exclude like the anesthesiologist, or it excludes the doctors, you pay for everything, but I mean, is it structured differently, or is it always all inclusive?
Mr. Chairman, for a bundled payment, it would include the total episode of care. So it should include all of those things. I suppose if it wasn't a true value-based care arrangement and some other negotiated bundled payment, that's not prohibited, but it wouldn't fit under the value-based care model. It wouldn't meet the threshold to be actually called a value-based care model at the different levels that are provided. Now, you can always negotiate a different type of payment that's bundled payment, and that's part of my question, I guess, today. I mean, we're talking about bundled payments. Are we talking about value-based care bundled payments specifically? Because there are requirements for those, as opposed to just sort of, I guess, having a negotiated rate on what you would pay a hospital or a provider for a service.
I think to answer that, that's why we're having the conversation, because we had that question and we're trying to get ourselves educated when the term's brought up, that we have a full understanding of what it's intended to be. And so I think moving forward as the task force, I will suggest that the definition for bundled payment would be all inclusive of lock, stock, and barrel. And then if there's a negotiated price, that may be any part of that. You might have a bundled for hospital and anesthesiologist and reimburse doctor separately, but that would be a negotiated payment, right?
Mr. Chairman, would we also be including quality and value as well? Because I think that would be important to the way that bundled payments are typically structured, is that you're doing it that way in order to build goodwill on the service by an understanding that it's being provided with the value and the quality that you would expect it to be provided with.
Well, I think so. I just took that as a given that you wouldn't compromise or dilute the care or the quality for the payment that they would have to maintain.
Mr. Chairman, yeah, I agree with you, and sorry, I don't mean to interrupt, but it would take measurement of that. So as part of that bundled payment, there would be a requirement for a measurement of that value and of that quality that will be provided. It wouldn't just be sort of, expected.
Some sort of deliverable.
Mm-hmm.
Is that right? Okay. I think we agree. Please, Karen.
I just had, thank you, Mr. Chairman. I just have one more comment because the state plan is so focused on ensuring that there is a choice, an open choice. So I just want to make sure if you guys can steer me down the right direction. Having a bundled arrangement, a bundled care contract arrangement doesn't specify steerage. I know that sometimes, correct me if I'm wrong, if there's a center of excellence.
But explain that, please.
Oftentimes, if there's a center of excellence, that's where you need to go for certain things. That's the requirement because it's going to save the plan and or the member a significant amount of money. The plan's all over taking a discount, on a service that may be overwhelmingly expensive, but it isn't something that because that arrangement's in place, members have to go there. They can still opt to go where they want to go. It's still free market.
And I'm going to ask for clarification again. I don't know that I quite caught that. Are they required then to go to the bundle payment, or do we still leave the option?
Well, that's, I guess, the question I'm asking for confirmation on, because it's important to the state plan that there's choice and there's not requirements to go to certain facilities.
Mr. Red, would you have any thoughts on that?
Mr. Chairman, I would agree. I think that we've talked a little bit about this today. We talked about free markets. We've talked about the ability to choose. What I will say is that we would always want to choose Wyoming providers. And I think that's why, I don't think that's why, that is why we're here today. We're here today as an insurance company to work with our providers here in Wyoming to find solutions so that we can make this work in Wyoming and not have to find other places to go to get cheaper care or even better care. And so until we find that solution, I think it's important for us to be able to go places that would provide better alternatives as a matter of choice to that member. And right now, I think that is something that our members expect from us, especially when we're talking about lowering premiums. If we're not able to do that, then the premiums are likely just to go up.
All right. Thank you. And that was a conversation. So, Madam Chairman, we have caught up. Well done, everyone. I think we'll take a 15-minute, we'll come back at 3:30 and start the last conversation day, healthcare on a trust considerations. So let's take a quick break. Well done. It's so entertaining. I've got a few of those, but mine's just a sheep probably. I'm in sheep. Thank you. Senator Taft is showing the latest portrait that he had commissioned, and it's very nice. Yes. We are on the last topic of the day, healthcare antitrust considerations. You'll recall at our last meeting, as we talked about the structure of healthcare in the state, I think that there's two things for us to consider. One is the competition issue that we talked about earlier this morning. There's not competition because we don't have the volume of people to really provide, to generate the revenue. So it kind of blocks competition from coming in. And so what we find around the state oftentimes is where we have maybe a hospital in one county sneaking across over to where another hospital is serving a population and opening up an office, and all in an effort to generate more revenue, but causes where one revenue is generated, the revenue is lost to the other. And so then that complicates our model a little bit. And then the idea of a hospital then comes into community and wants to make sure that they control, again, as a revenue generator, and make sure that all physicians in the town are associated or affiliated or belong to them, which then puts pressure on competition as well. And so I look forward to this, and we have the ability to ask a lot of questions or to help us understand the antitrust policies from the Attorney General's office is Christine McCabe. Miss or Mrs. McCabe, would you please again identify yourself and who you're with, and help us understand the context of this discussion?
Certainly. Good afternoon, Mr. Chairman, Madam Chairman, members of the committee. Again, my name is Christina McCabe. I am a deputy with the Wyoming Attorney General's office. I oversee our Human Services Division. Within that division is our Consumer Protection and Antitrust unit that does help to enforce our consumer protection and our antitrust laws. And I am here at the request of LSO and Representative Larson that I provide some information to you all to address the Attorney General's role and process in reviewing and addressing any potential antitrust concerns that would involve hospitals or hospital ownership transactions. So with that background, that is what I intend to provide you just some basic general information on. So again, as I said, within my division, the Consumer Protection and Antitrust Unit is my group of attorneys who would be responsible for enforcing our antitrust statutes. We do have several statutes related to antitrust. If you're interested, they're in Title 40, 40-4, 101 through 123. And just generally, 40-4, 101 is the beginning statute, which identifies what we're looking to regulate and prohibit, which would be those actions that would prevent or substantially lessen competition, create a monopoly, or something that would attempt to control or influence production or prices. That is a very broad definition to begin with. So certainly you can all appreciate that there would be a lot of factors and things that would go into deciding if any of those one things would be occurring. What our statutes do allow, we have a criminal enforcement, and we also have civil enforcement. So under the criminal enforcement, there is criminal enforcement with penalties that would be obviously prosecuted by local county or district attorney's offices. And then specifically for the Attorney General's office, there is a specific statute 40-4-114.1, which allows the Attorney General's office to engage in civil investigations of antitrust violations. So as long as our office has probable cause, we can begin a civil investigation. I'll make a small point with regard to probable cause. For many of us, when we hear that, we immediately think of a criminal standard and sort of this high standard to be able to start a criminal case or engage in those things. We do have Wyoming case law. It's Wildlaw LLC versus the state of Wyoming from the Wyoming Supreme Court that had an opportunity to talk a little bit about what that probable cause is. And so for purposes of today, I just want to let you know that it is actually it's a lower standard and much more broad when you're thinking about things in the criminal context. So that phrasing probable cause in our antitrust statutes doesn't equate to the same thing as you would see in a criminal statute. So we have a little bit more broader power.
Christina, help me understand. So are you saying all monopolistic or antitrust actions are not criminal?
I'm not saying that. There are two options, I guess, or you could have two things going at the same time. There could be the criminal prosecution. There could be a civil investigation. They're just separate things that are available under the law. So they could be prosecuted criminally. You could also have a civil investigation going. Obviously, if a criminal investigation would have that higher burden in the court of beyond a reasonable doubt. If we take civil action, we typically have that burden is lesser. So sometimes just sort of thinking about how DA and county attorney, how they make decisions on what to prosecute, right? The level of evidence for the criminal is going to be much higher than it would be for the civil. So one may be easier to pursue than another. Well, I can give I think I can give just a general understanding. I can tell you that in the time I have been with the Attorney General's office and I've been in the AG's in the Human Services Division, I don't think that our Consumer Protection Unit has at least definitely not on a state level, been involved in healthcare antitrust concerns within Wyoming. Certainly, our unit participates in various larger multi-state actions where several states get together, pool their resources, and sue entities in federal court. So practically speaking, Chairman, I don't have examples that I can provide to you because our unit hasn't experienced them and had to do them or had to do these investigations at this point. So generally, I think we all have probably a similar understanding that you all have, is that a monopoly is when, one company comes in and buys up all the other little companies, and then it's the only player in the game. And now we have a monopoly. And so we, don't want that to happen. Obviously, from this task force perspective, if you're focusing on making sure we have affordable healthcare and that we have providers available, that definitely comes into play. Certainly in a rural state like we are, there may be, sort of instances where we don't have any other choice when certain things, when certain things happen that way. I do think the law, although I don't believe that it's been used, I do think we have an exception that in the law, in the antitrust statute, that does allow some, I guess, what would be considered anti-competitive behavior if an exemption is requested. And so I can give you that reference. But again, it's not something that we have seen used. So
do we have any antitrust activity or monopolistic activities in the state that are allowed?
Under the exception, there is an exception allowed in Title 35 for health care cooperative arrangements. And those, if there's an entire process to request an exception under that. And so if it is one of these healthcare cooperative arrangements, basically on the surface, the arrangement looks like it is anti-competitive behavior. It looks like it would fall under, it would be a violation of antitrust. But because of maybe the needs of the state, the best interest of the individuals of the state, our laws do allow for an exception. So something that would actually qualify as behavior that could be investigated civilly or criminally. If this exemption has been applied for and received, it is a complete, basically it's a complete bar, and that activity is okay. Does that make sense? I apologize.
It does. I want to ask the question in broader than just healthcare. Just in Wyoming, do we have any services that the public feels is important that is monopolistic that we allow to occur? And if so, how then is there any controls?
Chairman, I don't know. I apologize.
So I'll ask the question, would perhaps electrical delivery
Utilities.
or natural gas delivery in a community be considered non-competitive or monopolistic?
I mean, again, I think it's going to be fact and circumstance specific, and I'm not sure if we already have areas where we have exempted those things under, again, just looking at our straight antitrust statutes. You'd really be looking at sort of that intent component, and is it meant to lessen competition? Is it meant to create a monopoly or control or influence? And so again, sometimes if there is, just by virtue of only having one entity that provides a service, that doesn't automatically mean that it's a monopoly or that there is an antitrust component.
What does it mean then?
Just means that we maybe don't have maybe the infrastructure, or we don't have, maybe our landscape is not attractive to other entities to come in and provide the service.
Fair enough, but then it's only one. And so then it appears to me that we allow that under jurisdiction, and we, like the Public Service Commission, to monitor and then regulate so that they can control price in geographic area even, right?
Certainly, Chairman, yes.
But I think that you could still look at those entities as being a sole provider and in control of pricing, and without regulation, that pricing could perhaps run amok because there's no other provider. But we control that somehow to make sure that appropriate increases are regulated. There's public input. They're allowed to make a profit.
Correct.
Right?
Yes, Chairman,
Thank you.
that is correct. And so again, for the Attorney General's role and process, really, as I said, we have that authority to do a civil investigation. How we find out about these things, though, is probably something, there's not a clear path, I guess, is maybe the best way I'll describe it. Our office would potentially learn about these types of concerns mostly in indirect ways. Our statutes do not have sort of, I guess what I would call pre-notice requirements. If, say, let's use a merger, for example, if two hospitals were going to merge, we don't have a state level pre-merger notification requirement. So for my unit, that means we would have to find out about this in some other indirect way. Ways that would happen would be through our general consumer complaint process. If individuals in the community were aware of this merger happening and had concerns, they could send us a consumer complaint. There are some things in the federal realm where we might also get some indirect notice from like the Department of Justice or the FTC. So there's a federal act, the Hart-Scott-Rodino Act, that triggers some pre-merger notification when a transaction exceeds a certain amount. I think it's $133.9 million. And so that notification on the federal side is required to be made to DOJ and the FTC. Our office has relationships with both those entities, and so likely we might get some indirect notification. So again, for this task force purposes, maybe that is if there are some concerns about antitrust occurring and how like that process works, we just initially don't have a particular notice provision that triggers that. So like I said, it would be very indirect. There is one sort of direct notification. It's kind of on the, I would call it bordering direct and indirect. Under our Wyoming Nonprofit Corporations Act, that requires prior district court approval for mergers that involve a public benefit or religious corporation. So if any of the hospitals were public benefit, nonprofit, they would be required to get prior district court approval. And then that requires written notice to the Secretary of State, who is then required to notify the AG. So that's a small little area where again, my unit might get some notification and then sort of go from there.
So with that last explanation, if you had, Fremont County is a good example, you had a hospital and two adjoining in neighboring towns owned by different private entities, different corporations. And then years down the road, those two corporations merge. That would make these two hospitals then merge. Would that requirement then apply as well?
So that requirement most likely would not if they were both private entities. That is another, I guess, bigger gap for private for-profit business mergers. Those companies follow their standard procedures, and in Wyoming there is no dedicated state level review board, and there's no pre-merger notification. So that is, as far as private industry is concerned, my unit would solely be relying on indirect information related to any type of merger like that. And at least on the surface, right, again, as I said, sometimes not every merger is going to violate antitrust violations. That is going to be a fact and circumstance specific inquiry. It's going to look at a lot of different components, many of which I'm probably not the person to help understand that, but certainly we've that fact inquiry. But that is, I guess, for me, that sort of notice requirement. And if you all are kind of wondering, how we would get involved, there maybe is a gap there because we would have to rely on very indirect notification to get involved.
So is in this task force, I think the most relevant thing we think of is maybe just within a county or within a community, one healthcare provider, a hospital, then buying up all the private practices, securing that consolidation. Is there a size? I mean, if the constituents, if the consumers complained, would they look at something that's only a county or a city specific thing? Does it have to be, or does it have to be broader? before they would consider, your office would consider investigating?
Chairman, I think initially, because we do have pretty broad investigative authority, we would most likely sort of just look at anything, you know, regardless of how it kind of presented to us, even if it was just in this one community. But with further investigation, right, then that may become a situation where after we've investigated, realized, no, this is fine, or yes, this is fine, or no, this is not fine, and we have to do something more. But at least for our office, anytime, any type of complaint that would come in that on its face would give us pause that there's a violation of the statute, we would at least engage in some minimal investigation to confirm if we need to go further. Does that make sense? So we would still take a look at it. Certainly it would obviously depend on what information was provided and what additional information, you know, we could get to kind of confirm some things. But I think the market, you know, kind of deciding who we compare our market with as far as, you know, Wyoming, you know, what other states we compare that with. Those would be things we'd have to, you know, consider once we have a situation in front of us to look at.
It appears to me and I believe that this the intent that the Attorney General's office is to represent the best interests of the state and does that. And so my question is not intended to be critical. It's really a question. Do you think the office does an adequate job of helping the public understand how they communicate these type of concerns with your office?
Chairman, I would say that we probably do a good job, but could do a better job. And I say that I think some of it comes down to maybe we've all sort of had this in our professions. People who don't do our jobs think that we sometimes can do more than we can. And I do think that sometimes that happens, that consumers have an expectation of what my unit can do and don't realize that it does have limitations. They don't have endless power. And although we do represent the best interests of the state, that is a fine line of representing the individual citizen. So I think we could definitely we can always do a better job of helping to educate the public on what services our office can provide and how, you know, what things that they see happening in the public that they should report to us, that they should maybe file a complaint. So that's certainly something, again, I think we could do better with. And get the word out a little bit more about what the unit actually does and what it's looking at.
You have any questions? Well, that was fun. Questions?
Mr. Chairman, real quick,
Please.
appreciate Christina being here. In addition to this unit that she supervises, she also supervises the unit of for the Department of Health and the stable of her attorneys and paralegals and staff. We keep very busy, so appreciate her being here today.
Well done.
Thank you.
Any other questions? Okay, I think the next one, don't jump up and run away. You never know when we might have another question on as we do this. Mrs. Bush, would you mind coming up? And you represent those physicians that are oftentimes in private practice and those that are employed by larger groups and might have a little thought on this.
Mr. Chairman, members of the committee, yes, Sheila Bush with the Wyoming Medical Society. I apologize for my voice. I know I sound a little ridiculous. I will do my best to not make you suffer through too much of this today. I appreciate the conversation. I know that part of this, I think, was inspired by some of my testimony in June around consolidation as a market driver or a price, a component to price. Those comments in June, I'll echo again in saying that any of my testimony today is not intended in any way as an attack or to land as adversarial to our hospitals who employ our physicians, many of whom are happily employed in those hospitals. And often it's the only mechanism that those communities have for any sort of healthcare in those communities. And so I would preface all of my remarks with some of this is national data. I think it's a really important conversation to have. I think it's really important that groups like this and the rest of the legislature understand all of the parts and pieces that go into consolidation, the vocabulary and the terminology. But I do want to sort of give the asterisks of not trying to pick a fight. So before we get started, it is a topic of growing concern across the country because the evidence suggests that especially in larger areas, particularly when private equity is involved, consolidation, whether vertical or horizontal integration, is a direct driver of reduced access, rising cost, and potential declines in care quality. Some of that is due to the erosion of a physician's clinical autonomy, policies that undermine the patient-physician relationship, and reducing already strained access to care as a result of closing underperforming practices or scaling back services, especially in those situations of several entities or hospitals that would merge in more densely populated areas where you maybe had more clinics that then they see under one umbrella as duplicative. For perspective and some vocabulary in terms, and if this is all stuff that you know, then I apologize. Horizontal integration is when within healthcare, horizontal integration is when, say, 3 hospitals were to merge together to create one, in that they provide the same services. Vertical integration is when a hospital were to purchase a physician clinic or a pharmacy, or that, they have this sort of entity. Private equity is pretty rare. We have 3 facilities in Wyoming that are owned by private equity. It's far more prominent around the rest of the country. And I think a lot of the data, a lot of the research that you'll find is related to the consequence of private equity's involvement in healthcare. And so Wyoming has been pretty lucky for the most part to be insulated from that. We still have pretty community-focused entities, even our, what I would quote, say, larger systems relative to that are pretty small still. But I think nonetheless, it's worth understanding, and it's worth as a state seeing what some of those market impacts are so that we can be prepared and know what those might look like. Just to sort of underscore the importance of this, in 2024, there was an RFI that was led by the Federal Trade Commission, the Department of Justice, and Health and Human Services. And together they did a large request for information. And what generated from that was pretty interesting. They decided higher prices and reduced patient access stem from provider consolidation. Horizontal hospital consolidation increases hospital prices from 20 to 40%, depending on the degree of concentration and market power. Vertical integration with hospital physician consolidation estimates price increasing range from 14 to 33.5%. Outpatient office visits, surgeries, imaging tests, and diagnostic labs were reimbursed at higher rates in hospitals versus non-hospital settings. And that has a lot to do with the site of service differential that we've touched on already today. When services are provided in an independent practitioner's office, it brings one single payment. But when the same procedure is performed in a facility, Medicare, for example, pays twice. They pay to the facility and to the provider. These fees are meant to cover hospitals' overhead, and those fees aren't associated with freestanding independent physician clinics, which explains a lot of that price difference. So to bring some of this down, I think national picture, I can give a little more just statistics and data kind of to underscore the importance. But I can also just kind of narrow this down to Wyoming. So in Wyoming, we're ranked 4th nationally in hospital availability and 36th in the country for affordability. For our independent physicians, in 2019, we had 225 independent physicians. That's dropped to 156, representing a 30% decline in 5 years. Independent medical clinics dropped from 2019 to 24. We had 168 independent medical clinics. In 2019, that's dropped to 112 in 2024.
What was the high?
The high number, 168 independent clinics in 2019,
112 now.
and we're now at 112, a 33% decline. We have 61 primary care.
Can I come back to that?
Yep.
Do you see that more in the consolidation more in rural communities, for Wyoming rural, okay, or in our larger communities?
I don't have a good answer for you. I could give you a guess, but it wouldn't be based on anything other than me guessing.
Yeah, guess.
Yes, I think that more consolidation is happening in rural areas. I think Casper stands out as an outlier, as a community that still has a disproportionate number of physicians maintaining independent practice. But that doesn't hold true here in Cheyenne. In Cheyenne, we have a disproportionate number of our physicians who are integrated within CRMC through CRMG, the physician medical group.
And is the reduction of private practice the result of consolidation or possibly retirement? Older physicians and no primary care physicians coming in and carrying on with practices.
So I think I have a little bit of that later on, but I think it's a multitude of factors that lead to consolidation or to physician employment. I think new graduates coming out of school, the idea of hanging a shingle is daunting. And so later on, one of my recommendations is that the state could put some effort into small practice incubators or small practice loans that would give a pathway to new physicians. Because right now, I think it's daunting. Hiring the staff, finding a building, renting it, buying it, building it, the legal implications, the cost of a front office and back office. Yep.
Oh, Representative Pendergraph. That's
Thank you,
what you were
Mr. Chairman.
waiting.
I have to ask if you think the affordability of malpractice insurance is also a factor in that consolidation.
Mr. Chairman, Representative Pendergraph. Sure. So what I will tell you is the Wyoming Medical Society will forever and always be a champion of anything that we can do to address liability reform. Do I feel like I have the best answer for you today in what that might look like? I don't think so. I think we have a lot to learn. I think there's a lot to unpack, and I don't know that it's going to be an easy answer. Today, when you have been talking about tort reform, am I correct in understanding that you mean a cap on non-economic damages?
Tort reform was put, which when you were referring to tort reform, was that putting a cap on damages?
Thank you, Mr. Chairman. I'm not sure that I would call it a cap, but certainly some limitations. Some parameters, sideboards, if you will.
Mr. Chairman, Representative Pendergraph, if you'll allow me, the last time the state had a meaningful conversation about that was in 2004. It was a special session. The legislature put an initiative on the ballot. I'm sure that you know all of this, but just even for my own saying it out loud, our Constitution prohibits putting any limitations or caps on non-economic damages. Within healthcare, that's most often what we talk about is never capping economic damages, but instead having the conversation around non-economic damages, which is often sort of in the lay referred to as pain and suffering. It's really hard to put a formula around how much a family has been harmed in the pain and suffering department. And that's where often you will see really large jury settlements. And so the states around Wyoming have all in one fashion or another capped those non-economic damages. It's also important to say that a lot of those are being challenged in the courts, and a lot of them were passed in the early 2000s and had automatic inflators on those. So 2% a year or whatever. So they would start at a $250,000 cap and they would grow. And so in the last 20 years, some of those have caught up. And I don't know if they are as meaningful today as maybe they were in the early 2000s. I'll underscore again that we want to be a partner in as that conversation continues I think that amending our Constitution right now and then coming back to the legislature and finding a meaningful solution might be a really interesting endeavor. And there are other options that the state could talk about and look at if we were really thoughtful and identified what the actual problem is and the best way to get to a solution together.
Continue, please.
Okay. I was giving you some statistics on just consolidation. Do you want me to continue those? Do you want to hear the rest of those? Okay. So we have 61 primary care physicians per 100,000 people. We have 206,242 residents that live in a health professional shortage area. We have 153,000 of our residents live in medically.
Can you define what a professional shortage area means?
I can Google it real fast.
Where I live.
A designation given by the Health Resources and Services Administration, HRSA, to places, groups of people, or facilities that do not have enough healthcare providers. You're
That's
welcome.
definitive, isn't it? Okay, carry on.
Okay, you're welcome. Okay, we have less than 300 individuals or physicians practicing family medicine statewide. And an important, I don't know, this added the stat that I think is just important as we talk about this is that, and I don't know if Eric has a different number, but I found about $141 million in uncompensated care that is carried by Wyoming hospitals. And I think that that just is part of the picture of what the financials look like in Wyoming. A RAND national, $141 million in uncompensated care carried by Wyoming hospitals. That was in 2024.
141. Over what period of time?
That was just 2024.
Just 1 year?
Mhm.
So then would their net income reflect that?
Yeah, I believe so.
Okay. Thank you.
Yep. A RAND study on national hospital price transparency found Wyoming among the higher priced states relative to Medicare. We were in the 250% plus range in the most recent rounds that included our state. Which just, again, I think some of this data is important. Some of it can be explained. None of it is meant as a statement about whether or not those prices are legitimate or warranted. I think it's just trying to get a handle on what our economic picture looks like in healthcare and where physicians fit into that and what the trend has been through time around employment and what potential impact that has had on patient choice, access, physician autonomy, and ultimately price. So you asked why physicians choose employment. We were talking a little bit about that. I think for new graduates, again, it's just really, really hard. For current physicians who are in independent practice who choose to go under employment, the American Medical Association did a survey last year and asked and the top 6 things that came out of that survey by physicians who had gone into some sort of employment agreement were the number one, ability to better negotiate higher payment rates with payers. So you have a lot of different leverage when you're part of a large system versus a small clinic of 1 or 2 doctors. Improve access to costly resources or allocating for fixed cost assets. I think the first things that come to mind for me are EMRs and the cost of maintaining those EMRs. A lot of I saw in my time at WMS, one of the largest movements to employment or to retirement, depending on where they fell in their spectrum of career, in the late 2000s, 2000, 2008, 2009, when we started passing a lot of laws mandating that physicians not have paper charts anymore, but instead use EMRs. We lost, yeah, sorry. Yes, and so they're really expensive and they require constant updates and a pretty sizable tech team to address HIPAA and firewalls and cybersecurity and, an office that was in charge of making sure they have really good locks and then paper charts in the back for them was a lot easier to maintain and provide the security around. As soon as everything went digital, which I think has a lot of really good qualities to it. Again, no blame being cast, but it created a completely different environment that made it incredibly challenging for physicians to stay independent.
Are the different EMR systems or products interactive? I mean, can you access one from another? Or is that part of the problem that, question?
Mr. Chairman, I would definitely say it's one of the problem. It is not a seamless communication space between the EMRs. The state of Wyoming, as you know, has taken a couple of cracks and I think is now in the beginning of at least a third attempt at building a statewide HIE, Health Information Exchange, which is designed to be sort of envision a cloud. And everybody's EMRs can push and pull in and out of that cloud if they have signed up to be participants in that HIE. Wyoming did our first attempt in, again, the late 2000s. It's called Wi-Fi. It's housed within the Department of Health. I know that we're at the beginning of sort of a third round of overhaul with that HIE, but could one EMR by itself talk to someone else's EMR? No. In fact, from personal experience, when my dad was end of life and getting cancer treatment, both here at CRMC and at UC Health down in Fort Collins, they're both on a system called Epic. And they are in a variety of ways connected to each other. And those two systems didn't talk to each other either. So if my dad got radiation in Fort Collins, his oncologist here couldn't see that information. If that radiation oncologist in Fort Collins wanted him to have another CAT scan, he would put the order in, but CRMC wouldn't get it. I would have to call, or they would have to fax the order to CRMC. So anyway, I could talk for another 10 minutes, which won't be helpful. But no, the answer is no. They don't talk to each other.
Director Johansson or Eric, can you help us on that health information exchange? If it's housed, is that something that's under your purview and what you're doing? Can you update us and tell us how that's going?
Mr. Chairman, I think on balance, it's hard to say. It's going well, and that's just in relation to how it operated before. As Sheila mentioned, it's been through multiple iterations, even an iteration prior to this legislature directing the Department of Health to take it over. Previously, it was operated by a community entity outside of state government. We are going through another procurement to change the model of how it operates, but I'll be general and mention that several years ago, the big problem was showing the value of the health information exchange to get more providers to participate in it. That has improved. We have numerous providers that do participate either as full participants or just receiving entities. So you can either put data into the health information exchange, take information out of the health information exchange, or both. We obviously want both. And the idea, as Sheila rightfully pointed out, is that for those who connect to the system and through various technological improvements over the past several years that have happened, you can get a full picture of a client and a system that communicates with multiple electronic health records. But again, the theory, I think, is easier to describe than the practice of full, use and execution of the data that's in that system. But we're happy with this committee or at the next meeting to do a more thorough briefing on it, get our technology folks over here that could explain it far better than I could.
Thank you. Eric, please.
Thank you, Mr. Chairman. I actually sit on the executive steering committee for the HIE. Are you on there with me too? Yeah. So I think we've got almost all of our hospitals connected now, but I do think we have what I think is potentially happening in this situation is we have a user problem where there's no training and they're not accessing it. We've worked really diligently to try to get all hospitals, clinics. We're trying to get nursing homes hooked up now so that we can have continuity care. We've come a long way, but I think it might be some training issues as well and some adoption issues with some of the providers.
Thank you. Continue, please.
Mr. Chairman, I think that's probably fair and speaks to, again, this incentive to be employed, right? If you are supposed to see patients from 8 to 5 and you paying a front office staff and your attorney and your accountants and the rent and the light bill is dependent on seeing those patients, where do you have the time to figure out how to learn a new system that changes really frequently and to train staff to like it's a grind that is almost impossible, I think, and detracts from what they really want to do, which is patient care. And so I think that that's it's a primary incentive for seeing the benefit of an employment situation in a larger system that has teams of people that are there to handle all of those different things. Whether it's the EMR, whether it's billing, whether it's somebody, whoever pays the rent bill, that doesn't fall on their shoulders the way it traditionally did a physician in independent practice. Other reasons that were cited, they were better able to manage the payer's regulatory and administrative requirements. I think this morning when you heard about teams of nurses where their job almost all day is just to be on the phone, whether it's with insurance companies or someone else, is real. Our small physicians don't have the capacity, and they're certainly not generating the revenue, particularly within primary care, where if you're paid on a fee-for-service basis, primary care is a relationship based practice. It's not a procedurally based practice. And we haven't, as a society, figured out how to pay appropriately and value the longitudinal relationship-based practice of primary care the way the way it's needed to, or the way it deserves, because we are in a fee-for-service structure. And so I think what Rocky was talking about earlier with value-based payments, there's a lot of good in that. It's just that it's also a mountain all of it on its own and comes with its own challenges and barriers and things to learn. Ease of participation in risk-based payment models was listed as a reason. Increased availability of additional resources that patients need. And you're better able to compete for employees in the labor market. So I think for our physicians who remain independent, securing help within those clinics is really hard because they don't have the same, they're not generating the same revenue to pay the salaries that maybe a hospital in the area can. So those were the 6 primary reasons given for physicians leaving private practice and going into an employment situation. So the primary reasons given for why consolidation drives up cost, and some of these are, I think, separate and apart from the presence of private equity, which is a little hard to tease out in the national data. As you research this, it takes a long time to try and get away from the data that is associated with private equity. But again, site of service payment differential. I know in June, Mr. Bowley testified that he doesn't feel like his members are charging that. And I don't have any way of knowing if they are or not, but it is consistently one of the primary reasons given for the higher cost of a physician service within a hospital versus in a standalone independent clinic. Commercial insurance bargaining leverage, referral steering. So that happens if a primary care physician is employed within a larger system or within a hospital, there are incentives or sometimes requirements that physician refer within the confines of that system. It may not always be that physician's choice. It may not be to the provider that they think is the right provider for the patient. So that's what I mean when you look at some of the reasoning and when you look at physician autonomy or independent clinical decision making, a lot of that comes down to referral patterns. So recommendations from the Medical Society. It's a range of things, and some of these I think I'll talk a little bit about tomorrow because today's topic and tomorrow's topic I think overlap a good bit for me anyway. But high level, just conceptually, they would be to preserve a range of physician practice models. I think that as this committee continues its work and the legislature in general, we figure out some of the answers to what government's role should be in this conversation. The ability to ensure that our hospitals can thrive. Every community and every physician, whether they're in independent practice or employed, is reliant on a sustainable hospital system where they can have patients go in and out of. They're very complementary to each other. The physician, I believe, is an integral part. I think that our system would be healthiest when there was a multitude of ways a physician could practice. They could be both employed, they could have independent practice. I think we'll hear more about direct primary care, and we'll touch on that more tomorrow, but that's another sort of model of practice that would fall underneath independent. One thing that my members asked me to talk about with you, and I will again tomorrow, but I think a state-run accountable care organization, or ACO, for physicians is potentially something that could be part of the conversation even this morning when you were talking about GPOs. Depending on what happens with that conversation, I think most of this morning's conversation was around hospital purchasing. But anything that the state could do to build a mechanism that has, an ACO for me, I think about, it's a partner regional administrative that could have entities with local primary care medical providers, creates a state-supported structure to coordinate physical and behavioral health, use shared data analytics to target high-cost care, and tie provider financial rewards to meeting specific patient health outcomes rather than a sheer volume of services. So in many ways, it's a structure that can help with some of the administrative burden. Maybe it's group purchasing, maybe it's whatever that we would decide it needs after a lot more research and consideration. But there are several states who have state-run ACOs that are really helping physicians remain independent. So I think that that's something to consider or put on the list. Potential partnership with the Wyoming Business Alliance or Business Council to establish the small incubator loans specific to independent practice. I don't know what would be permitted under current law for that, because I think a lot of the Business Council and business loans that are available have some restrictions, and most of those independent physician clinics would be private. And so I don't know what would need to be addressed to take down some of those barriers, but I think giving physicians low interest loans or grants in exchange for practicing in a certain area for a specific amount of time, similar loosely to how we fund the WWAMI program, wouldn't be a bad idea at all. I think there's a lot of good there to consider. Remove the barriers to physician mobility. That's what we were talking about with non-compete clauses. Protect physician autonomy and independent clinical decision-making, increase transaction and transparency. There are 2 states that recently, I think it's Maine and North Carolina, that do require any sort of merger or consolidation. Notice has to be given to the Attorney General's office directly. I think that those are worth looking at, just because not all of the acquisitions or mergers we're aware of, because they don't hit certain thresholds to trigger an antitrust conversation specifically, and they may not on their own be antitrust violations in any form. But I think having some transparency around that so that we have more data around this through time would be helpful. And then I do have, looking at liability reform and whatever form that might look like. So with that, I will conclude and stand for more questions.
Director Johansson.
Thank you, Mr. Chairman. Ms. Bush, just curious, was the membership referring to specific business mergers or acquisitions, or everything along that continuum, like affiliation agreements, those types of things? For the state to look more closely.
It was my membership that recommended the ACOs. It was a multitude of research papers I found and looking at what other states are doing around price containment and consolidation that gave the recommendation of a more transparent sort of just documenting of mergers and acquisitions. Yeah.
What's an ACO?
Accountable Care Organization.
Yes, I would. Please.
Mr. Chairman, Sheila, I just offered that maybe as we explore this opportunity we have through the WHA for the GPO and the direct pricing, maybe we can partner on that and help your members as well through your society or association.
Yeah, that'd be great. We'd love that. Thanks.
Okay. Don't run away. Dirk, please.
Okay, Mr. Chairman, Madam Chairman, members of the committee. Thanks again. My name is Dirk Dykestel, for allowing me to come back up here. Talking about healthcare consolidation, healthcare concentration, and we've put together a presentation that discusses market factors when looking at healthcare markets and how that's handled. So I want to start off by kind of a level setting and saying that I want to truly recognize that operating in a rural healthcare market or operating in Wyoming in general, no matter the industry, is extremely difficult. How often does this legislative body talk about retaining our youth, trying to attract business to the state? All of that is very difficult. And that is something that I want to start off by saying that's just a reality of operating in Wyoming. And Wyoming's affordability challenges aren't caused by a single factor. Despite maybe what we heard this morning or what I discussed or any other item, there's a very complex system. And that has real effects though. My 8-year-old daughter who has type 1 diabetes, when she goes in and gets treatment, that has costs associated with the payments that go towards that. Private health insurance companies, yeah, we have rising costs. Medical providers themselves, they face real operating challenges as well to provide that care here in such a rural state. And like we mentioned this morning as well, providing medical benefits to employees, that's also getting more expensive. So the issue is not necessarily trying to understand why, what to do about Wyoming's, overall geography or its rural environment. It's to understand how that has a unique effect on how our market is structured. So I want to start off by saying concentration isn't necessarily bad. It's a sign of the struggles that we all have. We have sparse population. We heard about low volume. We heard about workforce shortages. We all have recruitment challenges. We've also talked this morning about maternity challenges. Several hospitals have dropped that because of profitability concerns. No doubt, it's difficult. And long distance travel, economies of scale, these are all practical realities, and they absolutely explain concentration, but they don't eliminate the need to understand what the consequence of concentration is. And so we'll start off by talking about healthcare market concentration. And I gotta say, Director, I'm a little disappointed that your deputy's not here because I would love to have a grade on how I explain, an equation that's coming up here in a minute. But let's talk first just about, how healthcare markets are frequently concentrated. I had listed here prescription drugs, health insurance markets, physician markets, and hospital markets. We learned this morning that there's GPO markets that are also concentrated in the healthcare space. Seemingly healthcare as one of the most inelastic goods there is possibly, meaning that when there's a need or a demand, that doesn't go down just because the price goes up. If you need care, you need care. And whether that's a high price or a low price, you can't very easily delay that care. So concentration alone doesn't explain whether a market is functioning well. It also doesn't explain if it's functioning poorly. The important issue is to analyze whether the healthcare market itself has affordability, if it has access, and if there's quality associated with that market as well. We see this in different sectors. As the chairman already alluded to, there's other lines that have high concentration, and different sectors are subject to different levels of regulatory frameworks designed to protect consumers. That's, again, affordability is really coming back down to the consumer. How do we promote protection for consumers? And so in other lines of spaces.
Dirk, if I
Go
may,
ahead.
I want you to define concentration for us in this.
In this setting,
Mhm.
for what specifically?
When you're referring to concentration, is that the concentration of one entity in a geographic area? Is that the concentration of, I don't know that I'm fully understanding what you're referring to.
No doubt. I'll move forward just a little bit, and I'm going to come back to that slide because there's a very common measure that's accepted and actually promoted by the U.S. Department of Justice. This is the Herfindahl-Hirschman Index. It's also known as HHI. It's commonly accepted as a measure of market concentration, and it's been used for a long time. And what this does, it reflects the number of firms, companies, entities that are competing in a certain market and their relative market share. So to understand this on the HHI, when it's measuring the market itself, a low score, so something approaching 0, a very low score, means that there's a lot of competition in a market. On the other side, where it maximizes out at 10,000, that means that there is greater market concentration and there's less competitors in a market. So as the HHI increases, so does consolidation, meaning there's less competition. As HHI is low, there is great competition. The U.S. Department of Justice also acknowledges that anything over an HHI score of 1,800, so 1,800, is considered a highly concentrated market. So I'll go back really quickly before we get into the HHI. One of the things is that when we see high levels of concentration in markets, regulations are in place to help provide protections to consumers. We see this in the development since 1915, when the legislature here developed the Wyoming Public Service Commission. This was created by the Wyoming legislature in 1915, and it ensures that utilities in Wyoming are not only safe, not only are adequate, but they provide reliable service at just and reasonable rates. So the HHI, getting back to this, and to illuminate this a little bit more, there's the equation down on the bottom left. And what this means is you take the number of firms, number of competitors in a market, and you square their market share. So the percentage of the market that they have captured. And that will give you then the sum total of what the HHI is. So again, 0 to 10,000 is the range. Anything in excess of 1,800 points is considered to be a highly concentrated market. Health insurance markets are measured this way. So according to the Kaiser Family Foundation in 2024, the individual market, which is what we largely discuss here, so that's the exchange, ACA marketplace, you'll see that Kaiser Family Foundation shows that it's a score of 5,695, a highly concentrated market for individual health insurance. Similarly, the American Medical Association found that there was, in that same market in 2025, 5,054, again, a measure of a highly concentrated market. You'll see this also broken down by the American Medical Association's graph on the top right of this slide, and it shows the HHI total in specifically Casper and in Wyoming, or sorry, in Cheyenne, both highly concentrated. All these markets are highly concentrated. When you look now at the total marketplace, this is going beyond the individual market, going into large group and small group as well. The American Medical Association's competition in health insurance report shows that the HHI is 2,394 for health insurance markets as a whole. And it also breaks it down in Casper and in Cheyenne, shows the market share of specific competitors, and it takes the total market share and shows that it is a HHI of 2,949 in Casper, a little bit more competitive in Cheyenne.
Thank you, Mr. Chairman. Thanks, Dirk, for presenting this. I'm curious how we compare, say, to other states, especially in our region, for that concentration.
Mr. Chairman, Madam Chairman, Representative Geringer, I would say across the nation, you'll see this market shows that health insurance is highly concentrated. There is a few number of competitors with large market shares. That is not just in health insurance, that's in other markets as well. So I think that we're fairly close to other states. Some states are more competitive, other states are less competitive. I think the least competitive state was one of the southern states, and then one of the most competitive states was on the East Coast. So that's from my recollection. But Wyoming fits right into that mix. I don't have that ranking for you off the top of my head, but I can absolutely go back and get that and provide it to you. So that's health insurance markets. How we've approached that in Wyoming is different. So we talked about the PSC, and it's specific to price and protecting consumers, providing reliable service at just and reasonable rates. That similar line of thinking in consumer protection is also seen in the Health Insurance Commissioner statutes. So in health insurance, we have to file annual rates. Those rates need to be just. They cannot be excessive. They cannot be inadequate or unfairly discriminatory. That's all prescribed in statute. Further, there's also federal requirements on how our rates and our premiums are set. Those are done through what we've talked about before with medical loss requirements. There's the federal statute as well, and that requires insurers like Blue Cross to spend a minimum percentage of revenue directly towards medical care or quality improvement activities. And if we don't comply with that, we have to rebate or return that to the customer if those MLR requirements are not met. And common across this, when there is highly concentrated markets and where competition is limited or consumers face barriers to evaluating what is the price, what is the value that I'm getting there, Wyoming historically has accepted some form of regulatory oversight, and that might look different in different markets, but there is absolutely a precedent of showing that there is want to protect consumers. So Wyoming health insurance markets have been measured also by a Yale study. Yale study shows that with Wyoming's hospital markets, a score of 10,000 across the board. The map also shows that same score across all Wyoming counties for hospital markets. And the two counties that are in gray, well, there's no data there. In Sublette County, there's no hospital yet. And then in Crook County, there wasn't enough data for Yale to be able to evaluate that. Yale's study also showed nationally that 69% of hospitals are located in concentrated markets. But the key thing that came from the study, the key takeaway is that they observed that in competitive markets, competitors have higher prices that are largely associated with some type of distinguishment, where they are associated with improved patient outcomes. So you might hear of someone like, the Cleveland Clinic or other high hospital groups that are distinguished with high levels of quality, high levels of care. And in those competitive markets, you see higher prices are associated with approximately a 37% reduction in mortality. In non-competitive markets, higher prices were not found to have that same level of quality improvement. Instead, what a quote here from that Yale study shows is that in many of those markets where competition is not geographically feasible, Yale's evidence was that it highlights these concentrated markets, high prices likely reflect patients' lack of alternatives, not hospital quality. So Wyoming's geography may explain concentration. However, it still has the remaining question of what are those effects on affordability, access, and consumer costs. So in a free market, in a competitive market, you would expect to see that payment would reflect services provided, resources required to provide that service, and then the value delivered to patients or to the consumer. Healthcare reimbursement often isn't influenced by those factors. Sometimes it's also by who owns the facility. Competition may exist in outpatient settings. However, patients, employers, and health insurance companies, health plans may pay significantly different amounts for the same or substantially same service based solely on where the service is delivered, or more importantly, who owns that facility. We're going to go through a series of data like we did before, because I want to always bring you data-driven information. And here we're going to show again significant variability in the cost of service on the geographic region and the site of care. We profiled this from 2025 data alone, and the graphs are on the right-hand side. The map on the left-hand side, the counties that are filled in, that's distribution and frequency of this occurring in counties. So when it's darker, there's more frequent. When it's lighter, it's less frequent. And then some counties, we left them out because there wasn't an alternative. There might be a single point of service in that county, and we did not include that in the following analysis. So since there isn't an alternative for a member, a Blue Cross member, to go to another outpatient service in that county, they're not being considered or factored into the costs attributed to the site of care. Final caveat before I start going through graphs is showing that where there is limited number or a low N, we have indicated that with P, and P indicates professional setting that is not associated with a hospital. O is hospital outpatient, meaning it is associated with a hospital. So first we'll start with hip replacements. So the site of service differential based off of who owns the facility or where that's being delivered is reflected here in Blue Cross's data. Again, the counties that aren't filled in, that's because there wasn't an alternative, a choice to go to. But you see on the very left-hand side, there's a graph and it shows the average cost range for hip replacements across counties. In the professional setting, not associated with the hospital, you'll see a range of $20,000 to approximately $38,000 for the total cost of a hip replacement. And that is the payment that we actually render. Outpatient associated with the hospital ranges anywhere between $25,000 all the way up to $62,000 for that same service. On the right-hand side, you'll see that broken out by county. And we left this unidentifiable, mostly because we are trying to provide information. And you'll see that the blue on the bar chart going left to right is associated with physicians outside of the hospital, those total costs of that procedure, and then the facility costs or the hospital cost, the payment actually made is in orange, and you can see the differential there as well. In just 2025 alone, site of service differences for the same exact service totaled about $800,000 for the same service, only for Blue Cross patients. Knee replacements we talked about, and this is distinguished from the supply, the underlying supplies we talked about earlier. Again, starting on the left, in the sites not associated with the hospital, knee replacements go as low as $15,000 and range upwards of $48,000. Then the average payments for outpatient in a hospital setting starts at $30,000 and then goes upwards of $90,000. Now, this is only of those facilities or those hospitals that are located in an area where there is an alternative in the community. I want to put that important caveat because this dollar amount starts going up higher if you start factoring in areas where there is only one provider. Again, on the right-hand side, you'll also see the differential based off of the same procedure in a hospital setting and then also in the facilities or sites that are not associated with the hospital. And those are payment amounts. In 2025 alone, knee replacement, just due to site of service selection for identical procedures, were over $1 million to Blue Cross. Physical therapy. You can see the range on the left-hand side is much smaller on the professional, meaning outside of the hospital, starting as low as approximately $125 and ranging about to $200. For the same service provided in a hospital setting, that will go lower to just over $100, but range as high as $450. Right-hand side, you'll see that by county. There's more frequency with this, and there's also more availability across the state. Site of service differential for this was $715,000 or $719,000 due to the site of service selection alone. Colonoscopies. You'll see the site of service selection difference here was $2 million in 2015 alone to Blue Cross members. Professional services range as low as $3,000, goes up to about $9,000. Then associated with the hospital setting, it starts at about $5,000, goes all the way up to $10,000. The frequency is frequent, and there's a lot of availability across the state. This next one really hits home because this affects my 8-year-old daughter. When you go to a physician's office for an A1C test, which is a simple CLIA waived test that does not have to be associated with a lab, that means that if we get that at a physician's office, that test is approximately $30 capping out. as low as maybe about $15, but in the hospital outpatient setting, it starts roughly at about $30 and ranges all the way up to about $150 for the same exact test. You can see the frequency of which this happens across the state, and that differential just for A1C testing is approximately $169,000 for this test alone due to site of service selection. This also is in the imaging sector, where if you get a CT scan of the abdomen, if you do that in a physician's office, not associated with the hospital, it ranges as low as about $550 all the way up to $2,000. In the outpatient setting associated at a hospital, it begins at $1,500 and will range all the way up to $4,500. The site of service selection cost to the system, to Blue Cross members alone, is $760,000. This is not an exhaustive list. This is just a few that we have pulled out for illustrative purposes. It took a lot of time just to pull out this amount and be able to pull this from all of the data that goes into this. This is a frequent occurrence, and I would try and express this in a manner that is showing that this is not between this morning and this afternoon's site of service differential. What we're trying to show is that depending upon where you get healthcare, your price as a patient is significantly different. And that isn't necessarily due to higher quality. That isn't necessarily due to anything other than a site of service differential. It's nothing, maybe not even anything different than who owns that facility. So when we talk about how premiums are unaffordable, and I will be the first to admit that we have an unaffordable product, we also need to understand what's driving that. And not all things are equal. When you look at our pie chart, which is effectively what the dollar bill graph is, the overwhelming amount, so half of your premium goes directly to a single type of provider. 93% goes directly to medical costs. This is a very old study, and I'll be the first to caveat that. But this is the most comprehensive one I could find. I haven't been able to find a more comprehensive one that's Wyoming specific. And what this shows is the benchmark of what is actually paid. We can talk about charges, and we can talk about MSRP values, all of those things. That really doesn't matter. If you want to compare apples to apples, benchmark the amounts paid to Medicare. That doesn't change. It's paid apples to apples. And what you'll see is that the national average of the amounts paid relative to Medicare is approximately 240%, at least in 2017 when this was pulled from for inpatient costs. And there's several hospitals that operate and are paid under that. There's also several hospitals that are paid in excess of that. Inpatient is where you don't necessarily have a choice. Yes, Representative.
Dirk, wouldn't you want the majority of the premiums being paid? I mean, that's what we're paying is medical costs. So who else would we want the money to go to?
You have no argument from me. That's absolutely true. But we have to understand that when premiums are set and 93% goes directly to medical spend.
Of your premiums.
Correct.
I get that. Thank you.
So here the benchmark for commercial reimbursement. Again, some hospitals are absolutely getting paid underneath the national average relative to Medicare, and then others are higher. The inpatient setting is interesting because the inpatient setting is where you don't necessarily have a choice. In the outpatient setting, that is much different. You'll see the national average, at least in 2017, and this is information that was presented already to Joint Health and Labor back in, I believe, 2019, was roughly around 293%. But in Wyoming, we'll see some hospitals that are critical access hospitals, and they're billing roughly they're being paid roughly only about to 128% of Medicare. So they're well under the national average. But then as you approach other hospitals, you'll see some, and one in particular that bills all the way up to 830% of Medicare, or is being paid that. I should, again, be very careful with my words there. So when we're talking about concentration, and when we're also talking about the sustainability and viability of hospitals in the state, I would say that there are absolutely certain hospitals in this state that are struggling. There are absolutely certain hospitals in this state that have extreme challenges, and you have no argument from me from that. But I also think that the report that the Department of Health put together was pretty illuminating. It shows that some hospitals are also doing very well, and that the Wyoming hospital market, the provider market, is healthy. And take it as a large, it is absolutely a healthy market. So market concentration, and this is where I'll end this presentation, market concentration can affect how markets work. Affordability is real. Those challenges are real. And there's also challenges associated with operating in a highly rural environment. But the bottom line is that concentration isn't necessarily good. It's not necessarily bad. Understanding its effects are essential. And in areas we've also previously ensured that there's patient protections or that there's consumer protections. That'll stand for questions.
Questions for Dirk?
Yeah.
Director Johansson, please.
Thank you, Mr. Chairman. I feel like I'm permitted to give Dirk a hard time since he used to work for me, but if I overstep the line, just refuse to answer. So just from a naive perspective, what's the so what here? So understand the dynamics of Wyoming's market. We're rural, we're sparse, market concentration happens for a variety of reasons. So what? What do we want? What's being proposed to correct for that? Is there something actionable for this task force or for the legislature, for the executive branch to take away from that of what the next step should be, whether it's in the general healthcare market or the hospital market?
Mr. Chairman, Madam Chairman, Director Johansson, the so what is that we're here as this task force set to understand why private health insurance is unaffordable. This presentation was to show why private health insurance is also unaffordable. You don't have an argument from me that our product is affordable. It is largely a very, very expensive product, but it's also covering very, very expensive charges and payments. And so the so what here is what to do with that information. On certain insured populations, there are price regulations. You at the Department of Health have a fee schedule that you pay for Medicaid. I'm not arguing for that. That's not what we're advancing whatsoever. But if we want to understand where there's quasi price regulation, and then we often talk about cost shifting, if one is paying under, or if there's the appearance that one is paying under, that also moves to somewhere else. Earlier, we heard about hidden taxes on the system, but I would also say that where there is an ability to reclaim where underpayments are being made, there's also a lack of cost controls. So where there's a lack of cost controls, what that means is that it's going to show certain reimbursements or certain payments that are 101% of costs aren't going to be sufficient. And I can expand upon that if that doesn't make sense.
Eric, please.
So Dirk, I've been thinking about this quite a bit. And I don't know the answer to it. But it also shows that you guys are concentrated. And so are you guys too small? Is 90,000 covered lives too small to spread the risk? Do we need to look at increasing the size of your pool as well? And obviously we don't have people clamoring over the state lines to put new plans in place. But if you were to merge or partner with somebody and spread the risk, would you see premiums decrease?
Madam Chairman, Mr. Chairman, Mr. Bully, I really appreciate that question. And that's why I wanted to lead with it. I fully acknowledge that we are in a concentrated market. Blue Cross is the only domestic nonprofit insurance carrier, no doubt. We're regulated. Our prices are regulated. We have requirements on how we spend. Our prices cannot be excessive. They must be reasonable. While in this state, we just passed legislation for just the appearance of transparency on the hospital association, or sorry, on the hospital charges. So I guess that is how I would answer that question.
Mr. Chairman,
Sure.
I don't think you answered the question. So are you too small? And if you, I understand how you have to pay the claims, but if you have the ability to spread more risk, you have a bigger pool, whether you partner with another Blue Cross or whatever, does that lower premiums for all because you're spreading the risk?
Madam Chairman, Mr. Chairman, Mr. Boley, you know, I think that there is a need for competition in the market, whether we're high or low. We're covering the cost of what the charges are. We're making the payments to cover folks to ensure that they are able to get healthcare services. So we have requirements on how we pay, whether we have a larger pool. I don't think that that necessarily is going to bring down costs. At least I don't think that's going to necessarily change the premium amount. What is driving health insurance premiums is the underlying costs of medical care. So, you know, the question I don't know that us being too small is really a question that's going to drive affordability.
Mr. Ridd.
Thank you, Mr. Chairman. I help out Dirk here too. And, you know, I think your question, Mr. Boley, is the exact opposite of what we want to do. So what you would be talking about is further consolidation of the insurance market by us partnering up with someone else. What we want to do is operate in our service area, which is Wyoming, not with another blue plan, but to remain independent. And Mountain Health Co-op is a good example, right? They were a competitor in our market, a very small competitor, but a competitor, and they're no longer here. According to their statement, it had nothing to do with the competition between the insurance companies. It had to do with the cost of healthcare in Wyoming. So we're very open to competition, small insurance plans, big insurance plans coming in here. The more the merrier, really. So really our answer to that question would be no. We're not too small. You know, we would absolutely like to see more carriers come in here. But what we've seen is that they've exited the market, including United Healthcare and Medicare Advantage, because the cost is too excessive in Wyoming. At least that's the statements that have been made. So for us as a blue plan, we can only operate in the state of Wyoming. And that's where we operate. We want to operate. So we're not operating in other places. And in order for us to be able to do that successfully, we've got to work with the provider community to ensure that we lower the cost of healthcare here in Wyoming.
Mr. Chairman.
Madam Chairman.
Yeah, thank you. I'm taken back to how the focus of the committee changed from our last meeting, which was the cost of health insurance premiums follows the cost of health care. And it's the cost of health care that drives the cost of the premium, which is what we just heard. And one great example of that is the cost of health care over time in the country, right? So even when we saw the ACA become implemented, where you would think that created a very large pool, at least at that time under the ACA, it made no dent in that vertical line of the increase of cost of care. And so health insurance is just responsive. And I think to the point particularly of the nonprofit of Blue Cross, because they are so regulated, they're not going to make more, nor will the cost of healthcare go down regardless of their size. So I'd like to see that math work, but that's an interesting analysis. But since premiums follow the cost of healthcare and insurance coverage doesn't reduce the cost of healthcare, contrary to, I think, many policymakers over the course of years, except your uncompensated care gets higher. And that has to get divvied out somewhere, which probably comes to the concern over hospital pricing transparency, over how you're having to recover from uncompensated care in other ways. It's probably how I see how that money gets shifted around. Because you can't just take a loss. A hospital can't just take a loss, which the 1.4 million is spread out across all our hospitals. But you can't just take that loss, right? And say, oh, well, we have uncompensated care. We'll just keep operating and pay everybody their paychecks. So the money has to come from somewhere. And it comes from other services being charged and paid for that don't always make sense, which results in hospital pricing transparency because you're trying to recover from other areas, I suspect.
Eric?
So it's 141 million, not
Yeah.
101.4 million, but
Yeah.
a little bit.
What's a
of
few
difference.
million?
How you doing?
And it was just a question. I'm just trying to understand the economics as well. We're not afraid of the hospital pricing transparency. We're fine, post our prices up there as well. The reason United is getting out of the market I don't think it really has much to do with prices in Wyoming. United's getting out of the market in general because I think that Medicare Advantage has proven to be not what it was supposed to be when it was set up. And it's turned into a nightmare for a lot of the insurance companies. And they didn't have a very strong presence to begin with. They didn't do a good job in building adequate networks. So we can talk about that.
Mr. Chairman,
Last hit for last tap.
thank you.
Okay.
I would say that if you look at the exchange, you'll see that United Healthcare's premiums are much higher than ours. So I think that when you look at it that way, you're talking about Medicare Advantage, that's fair. I'm not sure what United Healthcare is going to do on the exchange, but if their premiums are higher than ours and they're a significantly larger corporation than we are, I think that has some anecdotal evidence to suggest as well, to your point. I mean, I can't speak on behalf of United Healthcare. I'm sure you can either, but we might hear more about that in the future, I would think. The other thing I would say is we talked about uncompensated care. If you look at that financial data that the Department of Health shared, we're seeing operating margins net, which is what we asked for last time, right? We asked kind of for that. We're seeing in 2023, it went from about 3.8% to 9.7% operating margin across all hospitals in the state of Wyoming. And that's for PPS, prospective payment system hospitals. So there was significant increase. And for the top 4 hospitals, net income in the state of Wyoming, that could wipe out the entire uncompensated care of 144 million.
Save it. So I think I'm going to wind this up because the question is why this conversation and what can we do with this? How does this help us move forward to, in the end, reduce or impact the cost of medical expenses? I think we look up why United Healthcare is scaling back higher medical costs, rural challenges, low patient participation in rural markets. Since I've been in the legislature, we've had challenges with having more than one insurance company in the state. But the problem for our health insurance companies is not unlike the problem that our hospital has. Big state, so if you're an insurance company, why come to Wyoming and cover a suburb of Denver and have to have offices and administration throughout the state? It's not a productive business model. Likewise, our hospitals are very essential. We've heard, all the years on labor and health and in appropriations, we've got to have more hospitals. And then the hospitals have to, Eric and I joke about this, have to do everything. The citizens demand that. And so as the information that came out from Libby and from Mrs. Bush today was that we rank very well as the number of hospitals and the number of beds available in the state. But the volume of people, so we're in this, we do not have the volume to support costs and allow our prices to be lower, which then would lower your premium costs. So we've talked about controls and we talk about, so we've got our hospitals there that are essential to the community. They're monopolistic, not by their choice, just other than my county, who's going to have multiple hospitals in a county. There's a lot of challenges with that. We don't see it around there. So my question then is how and what system have we used in the past, or are we currently using, that addresses these types of services in a rural setting, but are very essential to the community? And I come back to the PSC model for those essential services, which is currently gas distribution, electricity, has been telecom, to then help navigate the concerns that the public would have on how costs are derived, how then can we help hospitals make sure that they have a profit. They'll have to kind of determine what that profit is. Now, I know task force members, this is out there a little bit, but I only throw it out, and I just really want us to think about it and find the faults with that idea. We're exploring, right? So let's find the faults with the idea. Let's find the possibilities with the idea. And I'll just close with this, Madam Chairman, that then we'll make that as part of our stuff to be ready to report back to in October to see if this has any validity to recommend a continued conversation moving forward. But I would argue that we have to have a system that can address the uniqueness of healthcare delivery in Wyoming. And I just don't think there are, I would almost argue that there's no other state like Wyoming. I think Alaska might be the closest, but so I think looking for examples from other state becomes difficult. And I think we have to maybe think outside the box a little bit, maybe come up with something. If this leads to another idea, yippee, let's follow it through and get it to the end of the trail and find out why it doesn't work. But I think our obligation is to pursue ideas for the betterment of moving Wyoming forward. Would you agree?
I would.
Would you agree that we should call it a day?
I can't agree that much. I mean, that's not my nature.
I know, I know. Senator Taft, would you agree with me? Oh, let's table that motion. Okay.
Let's adjourn.
But so to all of those who participated today, Keith, thanks for staying. You hide in the corner over there. It's not punishment. But the wealth of information today has just been phenomenal. It's really been exceptional. Thank you. Thank you. The conversation. Do we have public comment? Okay, we'll come back to that. Eric and Rocky, I just love you guys for being here. And I know we feel your passion.
Jump in.
And it's okay. We're having very frank conversations, and you're doing great. Thank you. Appreciate that. And thanks for your various organizations' input and helping us have this conversation. This conversation would not exist were you not in this room. Just does us no good. Okay. Just does us no good. So with that in mind, Madam Chairman, I understand why you didn't want to call it a day, because we have public comment.
That's right.
Thank you.
That's right.
Thank you for the gentle reminder. Anahu, do we have anybody online? Nobody online. Okay, for today's viewing, for today's stuff, anybody in the audience that are in the room that would like to make public comment, please come on up. Love to hear from you. Okay. You gonna call it? Yes.
Mr. Chairman, I want to make one comment. I went to a congressional event this week and I played pickleball and I won an award. Apparently I was gone for the most honest, for hitting the pickleball out of bounds. So I did want to say, I made a comment about the top 4 hospitals being able to take out the full amount of uncompensated care. Again, a misstatement. I think it would probably be 5 or 6 or 7, but I just want to make sure I make that comment because I don't want to misstate the record.
Thank you. Thank you. With that in mind now, Madam Chairman? Now. Oh, sorry, Anna.
Sorry, Mr. Chairman. I don't know if you want to mention the Health Ministry's topic for tomorrow, that might be.
Yeah, thank you. That I think is a good time. So we had, we asked the Department of Health to prepare a summary of healthcare ministries and how they work. It's outside the insurance system, but as Representative Pendergraph noted, and as many of us have participated in, that's an alternative for more expensive health insurance. And the request was made to understand how that model functions and interacts within the state. Department of Health put together information based on what they could find. I received a call from an individual who represents a healthcare ministry, and after looking at the materials that we had online, felt that there was a number of significant flaws in the information and was prepared to make comment tomorrow to identify what he felt those flaws were. I think rather than do that, we ought to correct the flaws and come back with information that everybody would be on the same page. So I've asked, we won't be having that conversation in tomorrow's discussion. And then Franz and I will work with this individual to make sure that we iron out those wrinkles and can come back in October and provide information that everybody feels is defensible. Okay? So we might have, so you've got an opportunity to pontificate longer on whatever item you want. So, okay, now can we go on? Okay, thank you. See you tomorrow. This meeting adjourned.